Okay, thank you, Soren. Welcome, everyone. It's wonderful to be here with all of you today. I'm so grateful to each of you for your commitment to this campaign and to advancing health equity. This is my last meeting, a little bit sad, my last meeting with all of you as director of the campaign, and I'm so incredibly grateful to have had the opportunity to work with all of you to improve health through nursing. It has been such an honor. I cannot tell you. I'm going on to wonderful things. I'm not getting out of nursing, but a wonderful 25-year career with the Robert Wood Johnson Foundation. The campaign is in great hands. Together, we have strengthened the nursing workforce and advocated for nursing's value in helping all Americans to lead their healthiest lives. We created a broad network of national and state coalitions with over 2,000 organizations working together to achieve health equity. We improved access to care for people in 13 states, now 94 million people in 26 states. And the District of Columbia now have full practice authority for nurse practitioners. The number of RN to BSN graduates grew 252% from 2009 to 2020, while the number of doctorally prepared nurses grew more than 300% from 2009 to 2019. We know that most of that was through the DNPs, and we still need to very much work on the PhD. We help diversify nursing through mentor programs with Black, Hispanic, and American Indian, Alaska Native schools of nursing to retain and graduate their students. We help place more than 10,000 nurses on boards or decision-making bodies with strategic influence to improve the health of communities. And we've worked with Nurses on Boards Coalition to do this, a wonderful organization. And we raised more than $110 million in service of creating healthier communities through nursing. As we built the capacity of the nursing workforce, we set out an ambitious goal to unleash the power of nursing to achieve health equity. That's what the report is all about, the second report on the future of nursing, released just over a year ago. Can you believe it? We're celebrating our 1-year anniversary. And we set out a blueprint to do just that. The campaign committed to advancing the report recommendations, and this work continues with more urgency than ever. The survey results that Soren will share with you soon will show early progress pertaining to advancing the report's recommendations. As we mark 1 million US deaths, and I think I just read this morning that it was over 1 million deaths now from COVID, and 200,000 children who have lost a parent to COVID, a disproportionate number of whom who have been poor and people of color. We grieve. We acknowledge too how difficult the past 2 years have been for frontline nurses, and I might say faculty members as well, who have tried to teach our new nursing students. Too many nurses are suffering moral injury and leaving the field. We need to fully support all nurses. In short, we need to create a better future. We must work with as many partners as we can within and outside of nursing to lay the groundwork for creating a healthier and more compassionate America for everyone. I call this multi-sector partnerships. That's our North Star. And with all of us working together, I know the campaign in really wonderful hands will get us there. My colleague, Susan Reinhart, the Senior Vice President and Director at the AARP Public Policy Institute and Chief Strategist at the Center to Champion Nursing America and Family Caregiving Initiatives, will now say a few words. Susan.
Oh, thanks, Sue. And welcome to everybody. It's really great to see you virtually. As Sue knows, we really wanted to bring you together in DC, but of course, you know that story. So someday, I promise, we'll get you back, whether it's in DC or someplace else in the country. So thank you for joining us. And I know many of you are having trouble imagining the campaign without Sue Hassmiller. And you can just imagine, well, how I feel about that. We have been working together for quite some time. It's been 15 years since we co-created the Center to Champion Nursing in America, and then the campaign following soon after that. So I am going to miss Sue. I'm going to miss her energy, her ideas, her passion, her humor, her support, but she's not going to go far. I'm hoping she won't leave us too far, and she will be certainly part of the campaign in one form or another. But thank you, Sue. And one of her legacies is the number of people that are joining us today. So we have around 400 people who are on the phone or on this Zoom call. And we have nurses, we have educators, we have policymakers and business people, all of whom are committed to advancing health equity through nursing well into the future. And I can promise you that this campaign is going to go forward with great vigor. But I also want to, maybe we can go to the next slide, because where do you see this, right? This is, I know it's very busy, it's very colorful, it's very busy, but it is about the pre-summit survey that many of you filled in, and we're very grateful that you did that. And what it is showing is that many people at both the state and national levels are fully committed to implementing the recommendations of the Future of Nursing, the latest report, and that every recommendation has several organizations that are committed to those implementations. And many organizations have committed to more than one recommendation. So it's very powerful, and it's exactly what we need to be able to make all of this happen on behalf of those that we serve. So I'm really thrilled. I'm personally thrilled to be part of this campaign, of course, and to know that the campaign and the Center to Champion Nursing in America will remain a vehicle for this critical work, thanks to AARP Foundation, AARP, and of course the Robert Wood Johnson Foundation, who is making it possible because they're going to continue to support this work. So very excited. So I just want to say a few words. Sue already talked about this tremendous progress that we've made on access to care. We also call it removing barriers to care. And many of you know this, but we just want to shout it out that just last month, New York became the first large state to modernize its scope of practice list for advanced practice nursing. This is huge. It's a major victory. So congratulations to New York and to all those who have been working on it. And right on the heels, April 15th, Kansas had their governor sign legislation to adopt full practice authority for APRN. So we have a lot to be proud of. Winifred Quinn is like doing cartwheels right now, I am sure. Just to kind of give you those statistics again a little bit, when we started the campaign and the Center to Champion Nursing in America, APRNs had full practice authority in just 11 states. Now that number is 26 plus the District of Columbia. That's enormous. That's a huge, huge success. 94 million people now have access to direct care to advanced practice nurses. And there's been progress at the federal level as well. Nurse practitioners, clinical nurse specialists, physician's assistants can now certify for home health. And I'm a visiting nurse, so I'm particularly happy about that from my past work. And I know many of you were very involved in that success as well. So kudos to everyone. And I have to thank AARP, who funds all advocacy work on this, because of course the Robert Wood Johnson Foundation cannot be lobbying. So I always add that we have used those funds for both the federal and state level lobbying that AARP has contributed. This is really, really remarkable. And we just want to thank all of you that have helped to make CCNA and the campaign succeed in the work that we are all doing together. Millions of Americans, which I'm just talking about access to care. There's so many other things that Sue has talked about already, but it's because you've embraced the vision of these reports from the National Academy of Medicine, and before that, the Institute of Medicine. And we're just thrilled that we're going to be able to continue to work together. It's amazing to think what we can accomplish in the years ahead. So we have a lot of ground to cover today, and I'm going to turn this program over to Soren Kaplan. He's going to share some of the key findings of the survey that I've already mentioned. He'll do more of that, help us take our work to the next level. And again, thank you for those who did respond to this and for all of you for joining today. And after that, Soren's going to give us an overview of what we have in store for today. So Soren, let me turn it back to you.
Great. Thank you, Susan and Sue. I do want to highlight this slide as your moderator for the session, and my team has helped the campaign with the last several summits from the start of looking at the future of nursing and the impact and stewardship that the campaign can have in helping to implement the report. We did a survey, and as Susan said, this chart represents that there's action happening on every single one of those recommendations. So coming into the summit, we were really excited to help design, and I'll be your overall moderator today. Let's go to the next slide. And I just want to share with you some of the objectives that we had as we were thinking about this summit 1 year after the report came out. So the first thing is we wanted to celebrate the accomplishments, and we knew there were some, and we've seen a lot already, and we're going to talk about more today. We wanted to look at the progress from the field specifically, that, you know, the change makers that are really driving change related to this report and health equity. We're going to hear from them. We're going to really roll up our sleeves at the end of our summit with some of our action coalitions. We'll talk about that to continue energizing the existing stakeholders and engaging new partners in our process. And then finally, we want to promote new opportunities for engagement. We always see new opportunities coming out of these summits. So those were our anchor point objectives so that we could design this summit to meet these. So let's go to the next slide. Just a little bit of housekeeping on our agenda. So we're almost a wrap with our welcome and overview here. We're going to get into our keynote address, and well, one of my facilitator colleagues will introduce our keynote in a moment. And then we're going to move through a couple of different panels. We have some amazing thought leaders, experts, thinkers, and actors who are making change joining us, and you'll get to see the bios and meet all of them. We will then kind of do some closing statements and wrap the summit around 4:30 Eastern time. And we have an additional session for our Action Coalitions, Action Coalition co-leads, who will be participating in kind of a working session to understand how do we want to continue to take all of the amazing work to date and continue moving it forward. So that's what the last half an hour is, from 4:30 to 5 Eastern time. So that's our overall agenda. We'll kind of do our checkpoints along the way so you know where we are. Let's go to our next slide, and just a little bit of housekeeping. So our session and the chat is being archived and recorded, so you'll have access to that. We will be able to look at all of the great comments and ideas coming out of the chat. With that said, I want everyone to open the chat if you haven't already done so. We're going to be using this. I know that we're kind of in presentation mode here, but there's so much wisdom in our community. I want to have everyone introduce themselves now by your organization and location, where you are connecting in from. Now, I know we have hundreds of people here, so it's going to be a flood of chat introductions, but I want to capture that. I think it's important just to get a flavor for who's with us today. So your name will show up automatically, and we want to see organization and your location. Great, I see it coming in. Terrific. I see the energy and the interest flooding in. This is great. This is great. Thank you. Thank you. It's going to take me a while to go back up and read them all, but this is what we're looking for. Thank you so much. Okay, let us go to our next slide, because I want to dive right in here. I want to introduce to you our facilitators for today. We have Paul Leon and Piri Ackerman-Barger, both who have taken on new roles as senior fellows that will deepen their connections to the campaign that they've already had and really allow us to share their expertise more broadly. So Paul joined the campaign in early 2021. He's a former critical care nurse and founder and CEO of the Illumination Foundation. That's a nonprofit organization that helps homeless people in Southern California find stable housing and access healthcare. In 2019, he was awarded one of AARP's top honors, the AARP Purpose Prize, which recognizes innovators 50 years and older who are tackling some of the greatest societal challenges of our time, and not just tackling them, but inspiring others to join them in tackling them. So Paul, you'll be with Paul today as he works through works with the panelists and answer some of your questions. As you may know, Piri has been a consultant for the campaign since 2015, and she's been really integral to the campaign's equity, diversity, and inclusion efforts. She was instrumental in developing the campaign's equity, diversity, inclusion toolkit, and also mentoring the student support program, all while holding down her primary job as a clinical professor and associate dean for health equity, diversity, and inclusion at the Betty Irene Moore School of Nursing at the University of California, Davis. So clearly, Piri stays quite busy. During the panel sessions and during the keynote, you will have an opportunity to use the chat. During the keynote, use the chat to have dialogue about what we're hearing. We will not be doing Q&A in our keynote or of the keynote address, but we will be doing Q&A for each of the panels. So what I want to just highlight is Piri and Paul will be facilitating the Q&A following the panel. So if you have a question or you want a reaction to something you're thinking, make sure you say, question to panel or highlight the individual on the panel so that at the end of the panel, Piri and Paul will be able to address as many questions as possible. We don't know if we can get to all of them. So with that, what I would like to do is just again, acknowledge our extraordinary leaders, Paul and Piri. They've been named senior fellows of the Campaign for Action. You'll be seeing and hearing from them through the years ahead, as well as our summit here. And now I want to turn it over to Piri, who will provide the introduction to our keynote speaker. Piri.
Thank you, Soren. Hello, everyone. It's wonderful to be here with you today to celebrate all we've accomplished in the one short year since the second Future of Nursing report was released. Our progress is really remarkable, a testament to the dedication, experience, and talent represented by the individuals and organizations gathered here today. Our achievements also speak volumes about the report itself. It's fair to say that not every publication released by the National Academy of Medicine inspires this much purposeful activity. We're fortunate that the NAM Study Committee produced a document that both captures the issues facing the nursing community today and gives us a blueprint for charting a path forward. Of course, we also have Sue and Susan to thank for their extraordinary leadership. Together, they personify the term dynamic duo, so it's a privilege and pleasure to collaborate with both of them. Sue, I'm going to miss you so much. I love the humor, the passion, the way that you keep everything 100% real. And I'm really excited about the next chapter for you. I know that there's a lot of things coming up. I know this because I received an email from you this morning. So we're looking forward to the next chapter with you. Susan, we share your excitement at the prospect of continuing the work of the campaign, and I'm delighted that you will continue to lead us in this effort. Thank you both for all you've done to support the nation's nurses and to engage us in the broader effort to advance health equity. We are grateful beyond words. Today, we have an extraordinary lineup of presenters, and I have the honor of introducing our first speaker, Rear Admiral Aisha K. Mix. Admiral Mix is Chief Nurse Officer of the Commission Corps of the U.S. Public Health Service. In that role, she not only leads 4,500 commissioned Corps and civilian nurses, she also advises the Office of the Surgeon General and the U.S. Department of Health and Human Services on a wide range of issues. These include the recruitment, assignment, deployment, retention, and career development of nurse professionals. Admiral Mix brings a breadth of experience to her current role, having served in the Immigration and Customs Enforcement Health Services Corps, in the Office of the Assistant Secretary for Preparedness and Response, and overseas as a member of the first U.S. Public Health Service team to support the 2014 Ebola response in Monrovia, Liberia. She was commissioned into the U.S. Public Health Service in 2006 and placed at the Health Resources and Services Administration as a public health analyst. In that post, Admiral Mix increased awareness to the need to diversify the nursing workforce. She designed strategies to better retain and graduate nursing students from disadvantaged backgrounds. And she developed policies and programs to increase access to care for underserved communities. She will speak to us today about addressing structural racism to achieve health equity. Admiral Mix, thank you so much for joining us. We're all eager to hear what you have to say, so let me turn the program over to you.
Excellent. Thank you so much, Puri. I appreciate that introduction. So good afternoon, colleagues. I do want to first say Happy Nurses Month to all of the nurse professionals that are in attendance today. We undoubtedly continue to move through these unprecedented times. And as we come together today, 1 year after the release of the Future of Nursing 2030 recommendations, I really do hope that we all leave, fired up and absolutely in action. We've to date spent plenty of time assessing and analyzing situations before and during the pandemic. And so now it's really time for us to ask ourselves and each other, what's next? Next slide, please. So where I want to go today is to really focus the discussion about HHS's engagement and our work to increase address health equity by targeted efforts that shed light on structural racism. Those that also remove disparities that cause differing outcomes between races, and also provide some of the HHS agency tools in hopes that you might be able to utilize them across your organizations that'll help you also move in the right direction. Next slide, please. Some of you may be aware, in January 2021, President Biden signed Executive Order 13985, and this was titled Advancing Racial Equity and Support for Underserved Communities throughout the federal government. Executive orders, if you're not familiar, they provide direction to agencies within the executive branch, and they relate to a specific course of action. So this particular EO called on agencies to develop a comprehensive approach to advancing equity for all. It also identified the advancement of equity, civil rights, racial justice, and also equal opportunity as a responsibility of the whole of government. In essence, it required all of the government agencies to take a hard look at how we were doing business and also identify areas where there was unfair inclusion, access, and or services for people of color and others who have been historically underserved or marginalized or otherwise adversely affected by persistent poverty and inequality. Next slide. So at the highest levels of government, this charge included a focus on specific areas in order to develop and advance an equity and racial justice agenda. So the demographic data collection and reporting, as indicated here, what that reflects is the ability to determine whether our government services and programs and benefits are actually reaching all communities. A look at reducing administrative burdens and simplifying our government services is actually really taking a hard look at reducing the complexity of forms, as well as our enrollment procedures that were unintentionally creating barriers to accessing much needed services. It also required engaging historically secluded stakeholders, right? So focusing government operations on how people actually live, right? Not how we expect them to live or how we want people to live, but really understanding what is reality for people and how do we ensure that our resources and services actually align with that reality. It was also an intentional focus on equity and grant making. Many of you, I'm sure, have been a part of, preparing grant applications, whether it's individually or part of organizations. And we recognize that there are definitely unintentional consequences when it comes to accessing this grant funding. So this reflects an intentional reach to underserved communities and under-resourced communities especially, so that they are not only aware of the opportunities for grant funding, but actually can compete and compete effectively for this funding. So to date, over 90 federal agencies have actually developed equity action plans that address systemic barriers and also identify some innovative strategies to embed equity, racial justice, as well as gender equality in how we do business day to day. Next slide. So bringing it to a conversation of HHS, we are certainly committed to ensuring that every person in the country can achieve their full potential and also thrive. So the HHS mission is written out on the bottom of this slide, and I won't read it to you, But I do want to point out two specific terms because they really align directly with the approach that the department has taken. So when we say all Americans, what this means, and you all know it well, is it's all people, regardless of who they are, where they live, or where they were born, or their circumstances or identities, and a recognition that every single person deserves an opportunity, and they also deserve services in order to meet their needs. The other terminology is effective health and human services. I always remind people there are actually two H's in HHS, and we tend to forget about the importance of human services. And so HHS then works towards equity in many ways. And so this includes shaping when and how individuals and communities can actually use, access, and influence our HHS resources. So there's certainly a directive at the department level to move with a sense of urgency in order to not only assess policies, but to change them. And to change not only the policies, but programs and the processes in order to concretely advance health equity. And again, this is not just for now, right? This is putting something in place that can last long into our future. And so in order for that to last, there has to actually be a shift in culture, a shift in the allocation of resources, as well as a difference in our approaches. Ultimately, this drive to achieve health equity, it has to be institutionalized, right? And it has to remain a focus over time. Next slide, please. I want to talk specifically about three different areas that fall within the Office of the Assistant Secretary for Health, and that's where I'm situated as Chief Nurse of the United States Public Health Service. So go to the next slide, please. So the next slide will actually give you just a quick overview of what the United States Public Health Service Commission Corps is. As I mentioned, I serve as Chief Nurse. We sit as one of the 8 uniformed services of our country, and we are the only service that is solely committed to protecting the public's health. I also serve as Senior Advisor for our Public Health Service Minority Officers Liaison Council. The MOLC, as we affectionately refer to it as, it's a Surgeon General chartered group that advises the Surgeon General on public health impacts for racial and ethnic groups who are underrepresented in our public health workforce. Collectively, PHS officers represent one of HHS's deployable assets, and we are here, and most importantly, to serve our most vulnerable populations. Next slide. Also within OASH, or the Office of the Assistant Secretary for Health, is the Office of Minority Health. OMH actually exists to improve the health of racial and ethnic minority populations through development of health policies and programs that target elimination of health disparities. In a separate executive order, President Biden actually established the COVID-19 Health Equity Task Force. And we've heard a little bit this morning about, the impact of COVID, as Sue had described this morning. And this particular task force, it was under their purview where they needed to specifically focus on identifying and eliminating the health and social disparities that led to the disproportionately higher rates of not only exposure and illness, but also of hospitalizations and deaths that were related to COVID-19. So the task force proceedings from their minutes, as well as their final report and recommendations, were published in October of 2021, and they are available for public review. I included a graphic for the OMH blog on here as well, just so that everyone is aware that that is also another one of the resources that OMH makes available inside and outside of HHS and presents relative issues and relevant issues related to minority health. Next slide, please. And I'm certain many, if not all of you who are at the summit today are aware of Healthy People and the related objectives to improve health across the nation. The Healthy People 2030 objectives focus specifically and intentionally on addressing social determinants of health in order to achieve health equity. The 3 overarching goals are listed here. So a look at eliminating disparities in health and healthcare, addressing avoidable inequalities and historical and contemporary injustices, as well as attaining health literacy for all. Through a contract, the Office of Disease Prevention and Health Promotion, which is where Healthy People 2030 lives, actually conducted an environmental scan on how health equity and health disparities are defined and also communicated within public health. So that environmental scan, in combination with other information and resources that were researched, helped to inform the development as well as the dissemination of health equity and health disparities content, and also the new products that you have available to you within Healthy People 2030. Next slide. This graphic is one I like to use in a lot of my conversations related to this topic, because in any approach that's focused on equity, and particularly health equity, it's important to understand that action is actually critical at all levels, and it has to align with the socio-ecological framework, right? And this is a framework, many of you are familiar, but it identifies the systems within which we all live. And on this slide, what I've also done is overlaid diversity, inclusion, and equity in order to really depict how and where our actions have potential to have impact on the larger communities. So when we focus only on diversity, right, we are only focusing on identification and acknowledgement that there are true differences that exist between people. It's raising awareness, it's celebrating the differences, it may even include honoring the differences. As we move towards inclusion, though, we're now looking at creating inclusive environments, right? And these are inclusive environments that enable diverse people to authentically be themselves and feel comfortable being themselves. And we welcome them being themselves, right? So ultimately, what it does is it really removes barriers that might be in the way for people not showing up as who they truly know themselves to be. We don't stop there, though, right? So now we move it towards equity. And so when we talk about equity, here's when we bring in intention, right? This is an intentional approach that actually focuses on ensuring access to and empowering individuals and groups who have historically been disempowered in society. So it's at this stage really that action related to policy is needed. And what that does is it creates that institutionalized and sustained change that I mentioned previously. Next slide. So if that is a look at the generally accepted sociological framework and the overlay, what's always missing for me, though, is a centering of the person and a reminder that in the middle of it all, and I argue the most important part of it all, is really the lived experience of the people who are squarely in the impact of what's going on. As nurses, clearly this is old news for us, and it is really truly central to who we are and what we are able to do, in such a way that sometimes it's actually easy to overlook it. So I take this opportunity, though, to remind you, though, that this is exactly why we are an integral part of achieving health equity in this country. I might perhaps be a little biased, understandably, right? However, I will still say that no one does it better than the nurses. So we understand that in order to move towards access, empowerment, and equity, we must first understand the lived experiences of the individuals, of the communities, and of the populations to really understand what's at play as we move towards change. Next slide. Here's a piece that's really important to me. As we moved through COVID and we started talking about vaccine hesitancy and the reluctance for testing, and there were a lot of conversations about, well, why? Why is this happening, right? Again, I say it is extremely important to acknowledge not only the lived experiences, but also how historical experiences have impacted generations of people. When you point a finger at someone, there are always three pointing back at you, right? I'm sure many of you have heard that before. I say this to say that even within HHS, we have taken an honest look at really, what has been at play over the long term that has actually supported structural racism, right? So on the screen, I shared just two examples of these past inequities in treatment that continue to impact Black, Indigenous, and other people of color. So you have to understand how the Tuskegee experiment connects in with, again, vaccine hesitancy, limited access to healthcare among Black people. You've got to understand how limited to no access to adequate health services across generations, across Indian country, has led to poor health outcomes for Native Americans in both federally and state recognized tribes. Again, you must recognize and understand these lived experiences for people and their ancestors of this country if you're truly serious about achieving health equity by fighting structural racism. Next slide, please. So as I round out the final slides for my discussion today, what I want to narrow down a little bit more is into HHS's specific approach and what's been done within HHS to give you kind of a window into our world and perhaps leave some nuggets, some areas that might be opportunities for each of you. So in looking at this approach to addressing our internal barriers to achieving health equity, the HHS Equity Technical Assistance Center was set up, and it was set up and established to provide training and technical assistance for HHS offices with a focus on maximizing equity and outcomes for individuals, families, and also communities. The HHS Equity Action Plan, as I mentioned, one of the 90 plus that's been created across the federal government, is available publicly, and it does provide more detailed information, but I did want to just give you kind of a snapshot on some of what is in the focus of that particular action plan. So engaging stakeholders, as I mentioned, to learn and understand their unique health needs, listening to the stories, ensuring that those narratives are actually told and also incorporated into our work. One example of that is the NIH Unite initiative that was developed within NIH to address some of those systemic barriers that have posed as structural racism in the disparate accessing to research treatment, research environments for people of color. This initiative serves to identify and address barriers to inclusivity within the scientific community. We've also, within the infrastructure, provided more training and support in order to ensure that we've got the adequate and appropriate resources, including adequately and appropriately trained people. Collecting data, I mentioned that earlier, through equity assessments in order to narrow down what we're doing well and also where there exists more opportunities. So examples of this include some of the pilot equity assessments that were focused on our administered grants and contracting, the delivery of postpartum care, as well as Medicare benefit enrollment centers. The establishment of tools such as the Minority Health Social Vulnerability Index that overlaid some of the data that we already had available through CDC that identified vulnerable populations, but also overlaid that with a look at race and ethnicity to further delineate where services are needed. Another example is the CMS Health Equity Inventory that allowed an opportunity for us to conduct an environmental scan. And lastly, reviewing and revising policy, right, so that they accurately reflect our intentions. One really critical example of that was the establishment of the Office of Climate Change and Health Equity within the Office of the Assistant Secretary for Health. Next slide. This slide is one of my favorites. I do know that there's a lot on it. That's intentional because there's a lot of work to be done, right? So the HHS Office of the Assistant Secretary for Planning and Evaluation actually developed this graphic. It's actually based on an original graphic that presented downstream, midstream, and upstream approaches. And so what you see in front of you is what it looks like when it's been overlaid with HHS's strategies at each level. You'll note the relevance as well as the importance of individualized healthcare to save lives, some of the more community-based human services that help to sustain lives, and then the population-based public health approaches that address circumstances within which people live, things that we know to love as the social determinants of health. Next slide. And I know you probably were still reading that slide, but I assure you this information will be available and you'll have more time than you need to look through it in more specificity. So what can you do to address structural racism and advance health equity? So the recommendations that are listed here on this slide are actually borrowed from the HHS Equity TA Center. And I included them here because I strongly believe that these are some recommendations that are not only relevant for us within HHS internally, but are some that you can take with you to really assess where you are and what you can do in all of the places and spaces where nurses engage. So taking an honest look at your policies and correcting for any unintended consequences. Intentionally addressing past and present inequities, you already know what they are. Providing opportunities to hear from those who are most impacted and disenfranchised, and also aligning your policies, programs, and services based on their identified needs. It's not good enough to envision what you think is happening. It's more important to actually understand what actually is happening. Creating a culture that informs everyone of what you're doing now and what you're no longer doing, right? Don't leave it up to interpretation or guessing. Be open, be honest, and be transparent. And then lastly, shake things up, you know, or as it says here, challenge the status quo. But those who know me know that I love some good trouble, right? It really is my motivation. And I invite you all to welcome that as well. Next slide. So I started out today mentioning that we've done great work in identifying problems as they exist, and the time is long past for us to move into action. And so these last couple of slides I've utilized to provide you with some useful and action-oriented tools and resources to hopefully inform your next steps. And as I mentioned, my brain tends to work on this kind of socio-ecological framework that really looks at the different layers of engagement. And so I offer these to you in the same kind of focus. So this slide reflects some of the resources to reinforce personal responsibility and accountability at the individual level. They represent resources and tools that individual nurses can use in order to really understand where you're starting, to identify and acknowledge the blocks that you might have where you can't actually see your role in causing some of the structural racism and the impact on the communities that the programs might serve. Next slide. Additional resources are here, and these are resources that are targeted at the organizational level in order to guide the necessary assessments that will ultimately guide your next actions. Next slide. And finally, some systems level approaches. And these are the approaches that inform your policy and program development. The list on these past 3 slides is certainly not exhaustive by far, but I do hope that it brings you the same level of excitement, and it really, really causes that level of fire that it brings me. You know, as my family says, you know, don't talk about it, be about it. And I assure you that nurses are certainly about it. Next slide. So as nurses, as healthcare professionals, we have all arrived at this point on a different journey. You note that the focus of my presentation was not on simply the role of nurses. That was intentional because I affirm that we don't need permission or to see our names in lights in order to know that we are needed to engage. So instead, I ask that you leverage your education, you leverage your skills, as well as your experience to start where you are, to use what you have, and do what you can do to achieve health equity and right the wrongs of structural racism. And when it's said and done, you can then sit back, smile, and say, but of course a nurse did that. Next slide. So I thank you for this opportunity to share with you today. Thank you, Dr. Hassmiller, many times over for all of the work that you've done. Truly the blood, the sweat, and the tears that you've poured into this effort. I wish you well in your next endeavors, and I look forward to today's panel during the summit. Thank you.
Wow, thank you so much, Rear Admiral Mix, for a really enlightening our base knowledge, and thank you for your service. But I'm sure I'm speaking for myself, but others also, that was just so much information. I can't wait to go to those sites and start looking those up. Thank you once again for all you've done and continue to do. Great presentation. So next we will be going to talk about, we'll have our first panel. We'll have Nurse Chief Executive Officers Advancing Equity. And I've been so excited to host this panel just because the knowledge that we're going to gain and continue to gain is going to be incredible. And I want to introduce our first panel, and more of their bios will be on our Action Hub for full bios. So I want to start out by introducing Deneen Richmond, President of Loomis Health Doctors Community Medical Center. Welcome, Deneen. Regina Cunningham, Chief Executive Officer, Hospital of the University of Pennsylvania. Roberta Waite, Professor and Dean Select, Georgetown University School of Nursing. And Terry Sterling, Interim CEO, University Medical Center, New Orleans. So welcome.
Thank you.
Thank you.
So nice to see you all again. And again, thank you for all the incredible work you all are doing. So again, we have so many questions for you. We're going to try to use our time wisely. And I want to start out for one of the questions that, and we're going to invite our guests to ask more questions as we go along. But I'll start out with the first question to Deneen. And Deneen, what factors and or problems led you to implement your strategy that you're currently using at the Luminous Health Center?
Thank you, Paul. Yes, it's so great to be here with everyone today. So, we've actually been looking at this opportunity, and I like to think of it as an opportunity that we all have to really look at our diversity, equity, inclusion. In fact, at my organization, we call it our Jedi journey, and it starts with justice, equity, diversity, and inclusion. And so we've been on this journey for a little while now. And in fact, in 2016, we at Luminous Health, it wasn't at that point Luminous Health, it was then Anne Arundel Medical Center. But we actually had a governance-led health equity task force. And really, it was our opportunity with our board leading the effort along with our leadership team to really turn the mirror on ourselves and look at our data around our workforce diversity, around disparities, around how we were identifying and addressing social determinants. So all of those areas, and just hold the mirror up and say, how were we doing? And from that, we identified a number of recommendations that we've been working on. And then fast forward to what we all know in recent times, with this pandemic, and then, of course, the all of the issues, which weren't new issues again, but just rose to the surface again with the murder of George Floyd. And so, we said, maybe we need to raise the mirror again. Are we doing enough? Have we made enough progress? And we actually formed a what we call our HEART Force, which stands for our Health Equity and Anti-Racism Task Force. And we were able to see some areas where we've made progress, but some additional areas where we really needed to continue our efforts, including some areas around how we were delivering culturally competent care, how we were leveraging minority and local business enterprises in our communities to add to the economic engine, not just in providing care. And obviously continuing to look at our workforce diversity, our board diversity, and all of those factors. So that's really created our roadmap for how we have been, putting out what factors led to us to look at our strategy. And I'll continue sharing as we go along some of those areas that we have made progress, some areas where we still need to roll up our sleeves and do some additional work, and just how we're staying connected. The last piece I just want to quickly mention is how we're staying connected to our communities when we do this work. So that HEART Force, that Health Equity and Anti-Racism Task Force, yes, that also was governance led, but we had faith-based members from our community on it, social service agencies, public health officials, leaders from within our organization. So it's not just, us kind of being our own evaluators. We really invite the community in to help us do this very important work.
Wow, great. Thank you so much. The same question, I guess, Regina in Pennsylvania, politically, you guys had a huge election yesterday, and as stuff are changing around, the same question, what factors and problems are helping you implement that strategy?
Yeah, I mean, I think, similarly, for a while, the organization where I work has had diversity, inclusion, and equity on the agenda. It was like a foundational element of what we call our quality, our blueprint for quality, essentially. So it's always been a foundational component of us looking at quality. But I would say that in the past few years, we have become much more focused and much more deliberate, to the point where we are looking at our data, cutting our data in different ways and identifying where we have opportunities. And I think it was certainly very similar to what Deneen said it was certainly the focus really increased with the murder of George Floyd and with all of the events that really unfolded in the nation. People really started asking a lot of questions about what are we doing? Are we doing it enough? Are we doing enough? Are we doing it systematically? Or is it more like sort of pockets? And how do we need to look at the whole issue more comprehensively? Again, in our data, we had identified some opportunities, some differences in some of the clinical outcomes by population. And when we did that, we started to think about, well, how can we, what do we need to do to address those things? And we actually started to incorporate some very specific goals around health equity. And just to give you two examples, we identified a difference in maternal mortality in our BIPOC population. And so for the past 2 years, we have actually had a very specific goal at both the hospital level and more globally at the health system level. So across all of the entities within the health system around improving maternal mortality in BIPOC women. Similarly, we identified opportunities around colorectal cancer screening in our Black population. So just to give you a little bit of, Paul, you mentioned a little bit about Pennsylvania, just to give you a little bit of the lay of the land of where I am. We are a hospital located in Philadelphia, in the inner city of Philadelphia. And although it's a regional referral center, it is the local community for the West Philadelphia population, which is largely a West African population. And so we noticed that in this population, the rates of colorectal cancer screening were lower, much lower than we needed. So we implemented a number of programs around, working very closely with the community. Again, Deneen mentioned the community, and I would say that they have been very largely involved in how we think about advancing some of this equity work. But we put some resources and programs in place to support colorectal cancer screening and education in the community, and set up goals to really improve our colorectal cancer screening rates. So that's one example. I would say also that in addition to those specific goals, we have also made it a strategic and operational priority within, so, every year we look as an organization at what are the priorities for the year strategically. And I would say that over the past 2 years, we have really, really focused more on diversity, inclusion, and equity. And so, I gave you two specific examples that are clinical, but some of the other things that we have done are to set goals around education, for example. So ensuring that we have implicit bias training across all of the groups within the inpatient and outpatient settings, so that people are aware. I think education is a very important, and awareness are very, very important components of this within the organization. So ensuring that we have education around this, as well as a number of other initiatives. But those are just a few examples of some of the things that we have done. I would say that I feel as a CEO, this landscape is huge and the opportunities are incredible. So I love the saying that that we just saw from Arthur Ashe about, start where you are, do what you can. There's a huge, I think, sort of a huge opportunity when you really start to dissect this and to look at it. And, one of the questions that I have had is, okay, how do we ensure that we're hitting all of the really important things, and how are we prioritizing this work? Because there are just, I just think so many opportunities, and I don't want to take up so much time, but I hope other examples, we have the opportunity to present some other examples as we go through, because there are really, really so many, I think, opportunities that we have in this space. So thank you.
Yeah, you definitely will, because I'm going to come back to you on a couple of your plans and what you would do differently. But I can't think of a more diverse actual city with a culture than New Orleans, right? One of my favorite cities, but a lot of people go just to downtown and they don't go through the whole state and realize that it's just such a culture of its own. So Terry, that same question, what have you been able to implement there? I know you haven't been there long as a CEO, but what have you been able to implement thus far?
Thank you, Paul. And again, thank you for those generous comments about New Orleans. The beauty of certainly I've interim and I've been here 1 year, but I am a Louisiana native and have spent my career as both a CNO and a COO and now a CEO in the state and really doing work 70 miles north in Baton Rouge. I also had the privilege to co-chair the governor's Resilient Louisiana Commission during COVID to talk about how do we recover and how do we recover more strongly. And, you know, both of our other panelists have mentioned certainly the murder of George Floyd, but also what came out of the COVID data very early on in New Orleans. If we think about Mardi Gras and we lost some of our Zulu members and others who at the timing Mardi Gras was rolling as we didn't know that COVID was raging. That demographic and that early data led by our Secretary of the Department of Health, as well as our governor, it became really obvious early on that COVID was having an unequal response in New Orleans to people of color, and certainly also to people who were working versus those who could work remotely. And so those things have really informed how we've moved forward in our journey. At LCMC Health System, where I am working, they not only hired a chief diversity officer, but her title is Chief Diversity and Social Responsibility Officer, and really have made it a very broad and global approach. And rather than, I like to say, some people joined the moment after George Floyd, but there are others who are joining the movement. And I think if you really enjoy Dr. Mix's presentation, that's really about a movement. That's about transforming us and taking us to a new place. And that's really the work and the foundation that's being done here in New Orleans. And our work is being led. I have the privilege of working with a nurse anthropologist who actually is leading this effort, Dr. Mary Tony Flowers. And so she and I work collectively. She's certainly at the system level, and then certainly what's happening at the medical center. But we talked this week and we talked about using the nursing process as the way to assess, but we've really framed it as exploring, committing, immersing, affirming, and transforming. That's what we see as the stages. And so early on in the process, it was exploring, it was understanding the data. And you've heard whether examples from Regina about looking at the data, segmenting the data, understanding what the opportunities are. But to be able to not rush to something, you know, we've been really clear, we want to be thoughtful about our work. And as a safety net hospital, there are tremendous services. So it was just starting with exploring, what are we doing? How do we bring those things together? How do we connect the dots, and moving from exploring to committing? What new things are we going to commit to do? And often ask ourselves, what are things maybe we should stop doing? Because if we're going to commit to something at a greater transformational level, there may be some smaller things that are individual niche programs, but we need to maybe put that aside and really think about committing. As we then move from committing to immersing, one of the big first components around bringing this movement to another level is training for our boards and the governance, starting at our health system board. There's a program we call HELM, Health Equity Leadership Matters, and all of our board members, all of our system executives, all of our hospital CEOs, and all senior leaders are going through a multi-day series of really creating this body of knowledge that is consistent across the platform. We felt that our leaders certainly cast a shadow on the organization, and what's important to them and how they understand this work was important to leading the work and more deeper work in the future. So our initial investment has really been around immersing and committing at that governance level, and then getting to the business intelligence level so that we not only always look at data that is really deconstructed in a way that we understand what is the ethnicity of that population, how are we touching them, and really systematizing that we actually transform what our data looks like in the future. And so it really for us is we're in that committing, immersing, and then we believe the next part of that journey is around affirming and transforming. We want to take one or two issues. We do not want to boil the ocean, but in our community, we want to take one or two significant issues and longitudinally say, we want to transform and move this dot from X to Y over a period of time. Certainly, Regina mentioned maternal health and the disparities we know that we have in mortality. And so that's one, because we deliver babies in the city, that's kind of popped up as an important one and is getting some energy, but we want to be thoughtful about what dots do we want to move, and we really want to do things that are significant and transformational.
Wow, I love that. With the title was Chief Social. Can you give me that title again? That was great.
Chief Diversity and Social Responsibility Officer.
Oh, great. All right. Well, thank you, Terry. And again, jumping up north and to the east a little, Roberta, the same question. What have you implemented in Georgetown?
Well, good afternoon, and thank you for that question. I'm going to sort of segue because I'm in a unique space. I've actually been at Georgetown 2 weeks. So I come from Philadelphia. So I'm going to use that as an example because that's where I was for almost 2 decades, working. And I think this really lands significant in the work that I did at the Stephen and Sandra Scheller 11th Street Family Health Services Center, because our work was more community-centered, community-based. And so our approach in addressing this problem when we were talking about DEI really started almost a decade ago. And we came into this from the stance of trauma-informed care. We were working with our patients, our families, and community, and they were coming in experiencing a lot of trauma. So we started to undertake a trauma-informed approach. And in doing that with staff, the voices from staff really elevated many other issues that also needed to be addressed that were not part of that trauma-informed care model. And so that was our parlay into really working with diversity, equity, inclusion specifically, and racism. So we started this work back in 2014 and started an Undoing Racism group collectively with our staff. While we were looking at data as well, we knew we needed to work on staff who were also delivering the care, because it's our professionals that also need to be aware of, well, what does DEI mean and how does it impact my practice? How does it impact me as a person? What do I know about it? And in talking to staff, they collectively identified while diversity, equity, and inclusion are really important, so were many of the other isms when we look at gender and religion. What they really wanted to do a deeper dive on that they saw was a root driver was racism. So we started Undoing Racism sessions at our organization that was really staff-led and generated that impacted policies, but then also started learning. Education is really a foundational framing because we really have been absent a lot of our knowledge as it relates to racism, what drives it, and understanding what it is. So we started Undoing Racism groups. They have evolved over years. They're still happening now. So we're almost, like I say, entering into our decade. And I would probably say over the past couple years, we also started affinity groups and anti-racism advisory groups working with community members as well as staff members. So it really has been transformational. And I really like Terry's word when she used, it's more of a movement. So it's not a one-time thing, but it's really building capacity and working towards, which we're striving towards, is health equity. And if we want to do that for our patients, we actually have to start with ourselves.
Wow, that is great. I love that too, about not boiling the ocean. So staying right here, Roberta, question back in Philadelphia, and we'll just use them both. Roberta, was something as you outlaid it, would you do different I know a lot of times you go back and say, probably would have done this different if you're setting up a program. Is there anything in particular you could think of that you might have changed?
You know, honestly, what I liked about it initially is that it was truly collaborative and it was staff driven. So it was really open. It was at that time I wasn't in administration, but what was very curious is that it was staff led, but initially administration was not involved. It was truly staff organized, and then it was spread out amongst everyone within the organization. One thing I do wish we had started a little bit earlier was engagement with the community earlier around the process and having staff and community. But staff really needed to enhance, I would say, their racial literacy to have some common understanding initially. And that also evolved in working with community, which is really powerful. Because what's really unfortunate is that our society has been so conditioned to seeing and expecting so many of the disparities that we have. Many people have normalized it. So I would probably say engagement with the community a little bit earlier, but I do think it's been very powerful as a movement from a staff perspective collectively, and that has grown and it's been sustained.
Great. And then Dina, you have multiple facilities, correct? That you're overseeing?
So yes, so now since 2019, we've been Luminous Health. So I am the president at one of our acute care hospitals in Prince George's County outside of Washington, DC. But Luminous Health as a whole includes, we have a hospital in Anne Arundel Medical Center in Annapolis, Maryland. We have behavioral health facilities in a separate hospital. And very soon, actually in July, I'll have a inpatient behavioral health and outpatient, a whole continuum of behavioral health services on our campus here in Prince George's County too. So a lot of the work that we do is we look at it across the system. But I think, one thing that's important to note, and just kind of piggybacking a little bit on the question, what would you do differently? I think that when you are looking at things as a system, you need to understand the whole, but you also need to understand some of those unique differences in your local communities. And I think that particularly now that doctors has been part of Luminous Health since 2019, I would say that that's something that we are very, very much in tune to. So for example, when you just look at the demographics of our counties, 30 minutes apart, right? Anne Arundel County is about approximately, let's say, close to 70% white. Prince George's County has the distinction of being known as the wealthiest majority Black county in the United States. And, when you look at the county as a whole, it's about 64% Black, but it's a very diverse county. So 64% Black, 27% white, about 19-20% Hispanic, 4% Asian. So you can just see that richness in the diversity. So when we start looking at our data and the initiatives, so if I'm in a county, as I am, that is a majority Black, then my workforce should look and reflect the community that I'm in. And that's one of the things that we're looking at. Doesn't mean that we don't want the same diversity in Anne Arundel County at Anne Arundel Medical Center, but we really need to be in tune to, our service areas and our local community. So I think that's something I would say we've learned, or learning, I would say, along the way, is just how important it is to, stay coordinated and have broad and bold system goals, but then also make sure that we really understand our data and the local implications of those goals as we move forward.
Wow, that's great, because and can you talk a little bit more about that on the data? Because somebody, once told me, when you're working with the system like you are, and you're seeing a changing not only demographic but ethnic backgrounds, it's not stagnant, it changes. So how do you approach it from a system point of view? Is there any recommendations? Because that's a little bit different from your workforce, the clients you serve. How do you How do you combine all that?
Yes, I think, one of the things that we've tried to do is to really think through, so like I said, we can have, as we do, a set of strategies and actions and recommendations. And I do want to just stress that, going back to that really quickly to that comment about it being a movement, one of the things that I am so keen on, and I have to give Luminous Health credit as a whole for this too, is that there's a lot of people putting out statements and, we're in support, and there's not enough action happening to match the statements. Because if it was, we would be seeing some huge inroads in the issues that we all, in these opportunities that we're all trying to address. So just quick aside on that. But I'll get off my soapbox now, but back to the data. So when we look at our data, we do some programming and efforts together. So for example, we have a system-wide goal around increasing our workforce diversity. And we have certain system-wide policies and practices, mandatory practices that we have to follow. And they're all the right things to do. Just to give you a quick example, one of them right away is around, we follow what's widely known, I guess, from the NFL as the Rooney Rule, which basically says that for every single one of our leadership positions, that we must have a qualified diverse candidate in the finalist pool. So what that has done, so you could be even in an environment like what I described here in Prince George's County, and you could see, which was part of what I saw when I came in, that you may have a very diverse workforce, but what does it look like as you go up into senior leadership? What does it look like? I have this saying, I used to say, does your workforce in the basement, and we all know those departments that might be in the basement, right? Maybe you have your EVS, your plant, your operations, maybe your dietary staff. How does that look compared to the C-suite? How does that look compared to our nursing workforce and those who are directly delivering care? So even though we're in a very diverse county, we have to really take a look at that and say, how are we doing at the leadership level? And that's where, I would say we had some of the same opportunities that we found across our system. So having that rule, the Rooney Rule, as we affectionately call it, in place, has made a big difference. But just saying that you're going to have a diverse candidate, you have to have a number of strategies that stand and support that. So it has really changed how we are doing out and where we go for our recruiting. So we have formed relationships with HBCUs because we know that they can deliver a diverse nursing workforce to us. We've extended that to even HBCUs out of our area. We identified one in North Carolina and recognized that as we looked at their nursing program, I actually was given a hint from one of my board members to say, hey, my child is going to this school. And I looked at their nursing program and talked to a couple of the leaders down there. Guess what? Outside of North Carolina, the highest number of their students are from what we call the DMV area, DC, Maryland, Virginia, Northern Virginia. And so we was like, well, they may not be able to come on site or do clinicals with us, but what about if they could come and do summer internships? What about if we introduce ourselves to them while they're in nursing school? Because guess what? A large percentage of them may decide to come back to this lovely Washington, DC area and start their careers here. We form that relationship. So that's one other example. We also, as I talked about opening up behavioral health, we were very fortunate that we received a grant, a cap to support some of the capital needs. So a $20 million grant from our county executive, Angela also Brooks, and our county council. And I love that one of the things that may have been intimidating to us if we hadn't already been so far ahead on this work, but one of the conditions in that grant was that we needed to hire a workforce and demonstrate our efforts toward this. And this is literally what they put in the grant requirements, that we needed to have a workforce and show our efforts to get a workforce that was racially, ethnically, culturally, and linguistically matching the individuals who we were going to be serving. And that really helped us to kind of crystallize all of the work that we were doing. And we had to look very carefully at, where were we going to go to recruit, whether it's, therapists or social workers or psychiatrists or psychiatric nurse practitioners. And we've connected with a large number of the associations that weren't in our typical talent and acquisition pipeline. So whether it's the National Hispanic Association of Social Workers, and that's an area when we talk about that linguistically, that's an area where we have some opportunities. We aren't matching the growing Hispanic workforce, the growing Hispanic population is in the way that our workforce is currently what it reflects. So those, it really is about understanding your data collectively, understanding the unique nuances of how you need to look at that data, not just at the system level, because the law of averages can hide a lot of things, but how we look at it at individual facilities, how we look at it in job roles, and not just, at the overall level, how we're very intentional about, recruitment effort. And now we're realizing that we need to be just as intentional around some of our retention strategies as we continue to work on increasing our workforce diversity. So it's exciting work, it's hard work, but it's absolutely the right work to do.
Yeah, having data and then interpreting that data is something totally different. And I know, Regina, you first mentioned data that you guys were collecting in Pennsylvania. Can you talk more on what you're doing with that and addressing systems? Oh, you're still on mute.
Thanks,
There we go.
Paul. So,
Sure.
I think, my role is more focused on the entity, but I do have two acute care sites. And it's interesting, one of them, I hear the other panelists talk a little bit about some transitions they're making. One of them was a very, very interesting opportunity. We have been providing inpatient services for a hospital that is about 30 blocks to the west of us in West Philadelphia. And it's an interesting story how this came about, because it was not part of our original, hospital portfolio. But what happened is something that I think we're going to see more of across the nation in the wake of COVID, and that is we're going to see more hospital closures, right? And so there was a hospital in West Philadelphia, which is about a 98% Black community that was going to close. And so we knew this was going to be a huge issue for the community. And so, in terms of continued access to some of the critical services like emergency department, behavioral health, and some medical surgical services. So we partnered with a not-for-profit group called Public Health Management Corporation to develop a plan, really working with the community and Public Health Management Corporation to identify how we could potentially continue to provide services for the community. And so we're doing the inpatient work, but at the same time, we're developing really the concept of a healthy village. In other words, like a portfolio of robust ambulatory services for the population. And that has been, I think, a tremendous learning experience. You asked before what people might do differently. And I would say that, the one thing that I have really learned over the time that we've been working in this space has been how to work with the community, how to work effectively with the community, how I would have started that work maybe a little bit earlier. Coming from a background where you're used to doing really acute care and not working as much with the community, this has been just an incredible experience to engage them, to have their voice in what needs to happen, not only in terms of the delivery of the acute services and continuity of care, but also what do we need in the ambulatory setting and what are the programs that are important to the community in terms of things like, what kinds of ambulatory programs are needed. So that's been an area of focus. In the larger system that I'm in, I don't have authority over the entire system, but I would say that there's a lot of work going on in this space in many of the other areas within the organization more broadly that are focused on health equity as well.
Great. Well, we have, I could sit here and talk to you all day long. We have about 8 minutes to split that same question between Roberta and Terry. And then I want to remind the audience to use the chat room and have your questions ready, because we'll get to as many as we can. So I know, Terry, you outlined a little bit about your system. How do you present that at a system change to really implement true change?
For us, and just to build on when I talked about structure, maybe I'll make a few comments about, it's really about systematizing data. So for example, making sure our HCAHPS data, making sure we look at readmissions, making sure we look at asset limited, income constrained, employed, the acronym ALICE, you may have heard of those individuals who are working, but are working poor. So for example, when Deneen talks about, do you look the same from the basement to the boardroom? One of the things we looked at is what percent of our lower quartile workers who sometimes work in contract agencies, what percentage of them have health insurance? And so it's less than 30%. And so as a safety net provider, how do we then connect them to Medicaid and then connect them to care? And so it's just really structurally going through the data and understanding we have ALICE employees in our employee or in our contractor relationships. And so how do we begin to transform those experiences and look at that data to say, we know what the benchmark is in our employed workforce, but then do we match? And so it's taking that data even down to our contract workers. And then beyond what we're doing in our patient demographics and data structuralizing, our team member and contracted relationships, the last piece is a part of our community. And so really taking that same step of understanding what are the perceived needs in our community? What does the data tell us? We know from where we sit on 2000 Canal Street that your life expectancy in our zip code and the zip code contiguous to us is 20 years less than you live on the lakefront of New Orleans. Wow. And so understanding the why, and then understanding what, again, are the key drivers. We may be doing programs, but are they the true key driver to life expectancy and connecting the dots? And so one way that we're connecting the dots, for example, is we do an annual physician business plan where we invite our physicians to come and tell us things that they believe will help to transform the organization. This year, we added a rubric to that so that it aligned with our priorities. And interesting, out of that rubric came a program for diabetes and diabetes in the community. And so it's just structuralizing in a way that gets us to what are going to be the things that, what's the 20% of something that's driving the 80%, and then what are the core steps we can take as we then plant a stake in the ground. The other piece is vendors. We've not only gone to our contract, but let's look at our vendors. Who are our vendors? Who are our largest vendors? Understanding how do we talk to them about this type of work. So it really is structuralizing across in a very broad way, governance, leadership, those things, and then begin the work below, but making sure that we're building a system that will last, but also building a system that will transform.
Wow. Man, if I was going to open a hospital, I'd hire all you guys as my CEO. So I'm going to put my word in first. Roberta, we'll let you answer the same question.
No, absolutely. And so one of the things I would say that I continuously heard that was really important for us as well is that intentionality in hiring and looking at who you're hiring at all of the different levels. And when you don't see that reflective of the community, we have to ask why not. So that was one of the key things that we honed in on first, is that actually the hiring process and that whole procedures and the guidelines and the structures that were in place. And with that targeted approach, over the next 2 years, there was a drastic change. There were different processes in place, and we actually had that reflection, both at the administrative level, which we had only had one, to when I left, we had 90% reflective of community. So with intentionality and change, it can definitely take place. But I also think the other important piece is how can we engage more specifically for us, community, because we know things that drive health, that drive opportunity is education and access to good jobs. So how are you able to bring in folks from the community to have good, stable jobs, and then they could also have access to other things within your structure and system? So specifically for us, because we ran our health center in partnership with Drexel University, which was, again, educational system, plus with FPCN, those individuals are able to have access to free tuition. Many went back to school. We had a number of our individuals go back to school to get graduate degrees, to be able to move forward and go into higher levels and explore those opportunities. So I think we also have to look at who we're bringing in and supporting that succession planning and that development.
Great. I know before we open it up, I know we have Colonel Hope Williamson Younts, but she's a Deputy Court Chief, Army Nurse Corps. And we want her to come in and talk a little bit about Federal Nursing Service Council efforts. So Colonel Hope, are you out there in our audience? Let's see if she comes up here. There we go. Good afternoon. How are you? You're still on mute, but we would love to give you an opportunity to talk today, and thank you for us. Can you talk a little bit about the Federal Nursing Service Council efforts?
I sure can. So are you able to hear me clearly now?
Perfect.
Okay. Hey, thanks so much for having me today and being able to provide a perspective kind of from my own thoughts and then also from the interaction with our FNSC partners. So first, I just wanted to say what a great dialogue, and for our leaders and teammates and federal nurses, thank you so much for inviting me today to share on behalf of the Federal Nursing Service Council. And just so I can flatten the communication, as we say, I wanted to explain who all is in our Federal Nursing Service Council. So it's a united federal nursing leadership team that has global influence, and we are poised to address tomorrow's health challenges. But like the panelists and everybody has said today, this is a call to action, not just a call, but a call to action. And so I extend a personal note of thanks on behalf of Brigadier General Jack Davis, Chief of the Army Nurse Corps, and he's also the chair of the Federal Nursing Service Council. And to our partners, we have, like I said, the Army, the Air Force, the Navy, the U.S. Public Health Services, the Defense Health Agency, the American Red Cross, and the Department of Veteran Affairs. So you have quite the group here that has great input and expertise across the enterprise. And so for each of the representatives at the FNSC has done so many great things over the past year that coincide with the 2021 National Nursing Organization Future of Nursing Call to Action Shared Agenda. But I would just like to highlight a few. So in support of COVID-19 pandemic, we started off pretty quickly back in March of 2020. So these members across the Federal Nursing Service Council have supported numerous deployments, and then also supported world events, you name it. We've talked to some of the racial disparities that we saw as a nation and that we were confronted with the death of George Floyd. And that also impacted, us in the FNSC. So we had over 6,000 service members to date that have responded worldwide in support of the Department of Defense civil support authorities. And it's an open source, but we supported 31 different states in the Navajo Nation. And that's very important. 106 cities, 127 hospitals. And so we sent those medical teams out. I always like to say it was a diverse team and a diverse mission that supported a diverse population. So that's pretty big when we talk about racial, disparities and how we must have culturally competent care. When we went out to the Navajo Nation, we didn't know what we didn't know. So we always sent a team out to do we call a pre-deployment site survey to determine what is best suited for that specific area. And you can adapt that to, our population, how they learn. What is the infrastructure like? And we learned that in the Navajo Nation with pandemic, we talk about washing your hands and doing those kinds of things. But when you go back and look at it, and we find that only 35% running water in the Navajo Nation. Now, what do you think about that? Don't be so quick to judge. You have to really understand what is needed in those environments to make the biggest impact. So I wanted to point out that, as nurses, we are in a prime position to use our voices and make sure that, as we say, we're working upstream to handle those downstream issues and concerns that we see each and every day. And so I know my time is limited, but I wanted to point out just a few things, a few thoughts too. And then if the FNSC partners, you're out there, I would, you can also, chime in on some of the things that you're doing. But the recommendation number 1 in the Future of Nursing report, it specifically speaks to creating a shared agenda. I think it's recognized that, we have the military collaboration with our civilian partners, which is so very important. And that is the way we're going to get after health equity. And so inside of recommendation number 1, it talks about the FNSC specifically collaborates with partners in the National Coalition of Ethnic Minority Nurse Associations with the support from the government, payers, health, and healthcare organization foundations. And so we realize this is not a nursing issue, but we're in a prime place to, as Dr. Hassmiller said before, go multi-sectoral, if you want to say, go across cultures and make sure that we have a multidisciplinary effort, is that we make sure that we have health equity everywhere and diversity everywhere. So within the 1.1 says within nursing organizations, we need to assess and eliminate racist and discriminatory policies, regulations, and systems to dismantle structural racism and make sure we have health equity. Also looking at some of the things that we've done, and we've done many, but there's a couple things that stand out, especially with our partners at the uniform services. And with our partners over at the uniform services, as you know, they have the Graduate School of Nursing. And so that is a diverse platform, but I think still, what is the goodness out of there? So across our academia, we have to ensure that we have adequate representation. And then we also have to make sure that we incorporate the proper diversity training. So when they go out and they leave that space, again, I use the Navajo Nation as an example, but they will be able to provide that culturally diverse care. So I think that's pretty important on that, is that we make sure that we are providing the correct or the appropriate education, if you will. And we have been doing that through the USU. And so the partners out there, they're getting ready to graduate on Saturday, just doing a phenomenal job for us. And so thank you to our USU partners. The other one I want to also bring out to the forefront is how we practice. And I believe that the future of nursing also says that you have to give nurses the platform and the opportunity, no matter where they work, to be able to be equipped to also create this diverse environment. And so when I look at the military, the medical treatment facilities is what we call them, even in the VA, how are we equipping our staff and our nurses, again, to make sure we get through and also provide information on health equity. Generally during a visit, we don't talk about we don't even look at sometimes, sad to say, the social determinants of health. That is where people, where they eat, sleep, work, and play, and worship. But that does have bearing, and that was borne out with the COVID-19 pandemic, where we saw people of color, because of comorbidities and those kind of things, succumb to COVID-19. So it really does matter that we get upstream. If we wait till the bodies float downstream, we're really about 30 years too late on that, some of the articles say. So it's very important that we continue as federal partners and civilian partners, and that we link hands and have crucial conversations. And then the last piece, I think the environment that we have is conducive to learning and action as federal partners. If you look at us, we're from all different walks of life, very diverse group, and we're a little bit opinionated, but we all have a heart to serve. And so again, it also starts, as one of the panels said, is, hey, consider a self-reflection. How it starts with you. How do you approach this? And I have to say, you do have to have moral courage and bravery when you're speaking about this. But I would say to you, the leaders online, don't be shy. We have to get after this, and it's not a we or us or them problem, but it's a problem. Martin Luther King said, if there's injustice anywhere, it's a threat to justice everywhere. So that's pretty important. And this is an important topic. And I just like to thank you so much for, allowing me to share today.
Thank you so much, Colonel. I love that. We don't know what we don't know. And thank you for your humility and your service.
Yes, sir.
I'm going to try to get to as many questions as we can, but this is to all the panelists. What can communities do together to eliminate disparities between zip codes? And so chime in, it's to all the panelists. The question again is, what can communities do together to eliminate disparities between zip codes?
One model that I'll share is that I know that when I was in Baton Rouge at Our Lady of the Lake, we fostered the development in partnership with the mayor's office, led by a nurse leader, Coletta Barrett, a community needs assessment. Actually, the first multi-hospital community needs assessment was done there. And so rather than every hospital having their own plan now, and I know that model has now been adopted, but I think not only a community needs assessment, we then partnered with the mayor's office under Mayor's Healthy City and ran all of our strategies through that lens. And so I think to that point, there are opportunities for us to understand. We wanted to move the dot on HIV in our state and in our region. And so we knew that we couldn't do it with one hospital doing HIV testing, but another hospital not doing it. And so we identified the top 5 priorities. So I think the community needs assessment, but across your city is one way, with stated strategies, again, about what dot are you moving? Not that you're trying to make it better, but let's be clear, we're trying to move a dot as it relates to diversity, inclusion, and equity in this space from X to Y. And that's one model that we've successfully used in Louisiana.
Great. Anybody else?
Yeah, I think just to add on to that, really bringing together the collective is really going to be important, because I think in many of the communities that are intentionally under-resourced and disenfranchised, there are many commonalities or themes that are there. So I think targeting and focusing on very specific things, leveraging that with legislation, representatives within the community, and bringing together those strengths to uplift key areas, as was just stated, is really important, because there are common themes throughout many of the communities that are under-resourced.
Yeah, I would just add to that, Paul, that I think one of the things that we've done is to partner with legislators. They're, representing the constituencies and, often have the same kind of goals that health systems might have. So we've partnered recently on some issues related to gun violence, and I think, within the West Philadelphia community. So I think that can also be another effective strategy.
Great.
And I would also add to that, in addition to the legislators that I mentioned before, I would even target and tap into some of the foundations. So community can come together collectively and work with foundations that have aligned mission and vision to really move efforts forward as well from that health standpoint.
I'm going to add one more, Paul, because I think actually you're making me think about it as we have this discussion. We've actually also partnered with payers. So payers have an interest, because if we do things that improve health in the community, it lowers their costs. And so we've been working with Independence Blue Cross here in Philadelphia as one of the key partners as well.
Yeah, let me echo that. So when I talk about that Mayor's Healthy City, the payers are in that at the table. And so your foundation and your payers are good funders for many of your initiatives.
Wow. I want to thank you all so much for your leadership and your service. Thank you so much. Soren, I'm going to kick it back to you so we could keep on time.
Great. Thanks so
Thank
much. That was really, really incredible. I'm going to transition us to the agenda for our entire summit. And just as a reminder of where we are, amazing keynote, incredibly insightful panel 1. And we're going to take a brief 10-minute break. And then we're going to get into panel 2, which is about addressing structural racism in nursing. I'm sure it'll be equally insightful and powerful. So with that, let's take 10 and be back in 10 minutes. We're going to pause the recording and just put ourselves on mute, and we will start at 5 minutes to the top of the hour. To the summit, I'd like to just give us a reminder about where we are in our process. We've done the keynote, we've gone through panel 1, and now we're about to go through our next agenda item, panel 2. Before we do that, I do want to just acknowledge the chat is great. All of you are really engaging. And there's even something I'd like to make a request of anyone who's from an action coalition, whether you're a co-lead or whether you're a participant in an action coalition. There's been a great conversation about the things that you can measure within the health system or just general measures as you think about creating a dashboard that elevates what you're doing out there in the field, as well as raising that up to kind of a meta level. If we had a dashboard to really gauge the kind of impact we're having, what would those measures be? We want you to put them in the chat. So give us some ideas for things very specifically we can measure as quantifiably as possible. We'd like to make that request of you. And we know that a lot of you submit kind of end of year summaries for your grants. We're going to ask you for that as well at that time. So keep thinking about these measures. It's really important. You kind of get what you measure, and we want those ideas from you. So with that, what I'd like to do is turn it over to our other facilitator, Piri. You're going to introduce and lead our second panel. Take it away.
Wonderful. I am so honored to be able to introduce this wonderful panel. Welcome, everyone. The first person on our panel is Whitney Fear. She's a psychiatric mental health nurse practitioner for family health care. Our next panelist is Katie Boston Leary. She's Director of Nursing Programs and Healthy Nurse, Healthy Nation, American Nurses Association. Carly Zagers, Dr. Zagers is Treasurer of the National Association of Hispanic Nurses. We have Dr. Anne Gakumo. She is an Associate Professor and Endowed Chair for the Diversity, Equity, and Inclusive Excellence at University of Cincinnati. And then Joan Gallegos, who is co-lead of the Utah Action Coalition. So if you don't mind, I'd like to start off with Whitney Fear. It's wonderful to see you again. It seems like it's been a few years. Congratulations on the new film that came out. It was absolutely wonderful. So Whitney, our question for you is, talk to us about efforts in public health nursing, as well as efforts in your area to address racism, particularly in respect to racism experienced by Native American peoples.
Thanks, Piri. It's so great to see you again as well. Cool to see some familiar faces and names out there as well. So with that question, I think that whenever I was kind of preparing, I was kind of trying to think of some of the most significant things that had been done between when like last year's summit, this year's summit, and then it kind of last week, there's sort of like one of them plopped into my lap. And that was the report that was published by the Department of Interior last week on their kind of the initial conclusions from their investigation into the role of Indian boarding schools in the United States. So, with that, there was a lot of information that came out about that and a recommendation to continue to study that because of the information that came out in that report. And I know there might be some people wondering like, what would that have to do with anything? And maybe there's a lot of people who don't even know what I'm talking about right now when I say Indian boarding school. So I'll quickly summarize, and for those who aren't aware of what boarding school was up until the Indian Child Welfare Act in the late 70s, it was commonplace and also legally enforceable for the federal government to mandate Native children to boarding school, military style, some religiously based boarding schools. And so that practice went on for well, they know now. I think the first one that they found open in 1801, so from 1801 to 1978 roughly, went on longer in Canada until 1996. But at boarding school, there was forced removal of cultural practices and language, and then displacement from families and things like that. And so that report also, the initial report also found that there was a substantial probable mismanagement of funds too from the federal government. And that's important because those funds are also the ones that are used to fund Indian health services and other health related programs. And in the past, that has been a finding in other cases. Some people might be familiar with the Cobell settlement, which was found. I think that settlement ended up being over $400 million. But that was also a mismanagement lawsuit kind of thing. But that could result in some potentially increased funding or reallocation of funding, which we know is, there's a lot of issues with Indian Health Services and the allocation of healthcare for Native American people, which is a treaty entitlement for us, which is another thing a lot of people don't know, is that is essentially a payment from the United States government that was promised in the Fort Laramie Treaty of 1868, and then reinforced by the Snyder Act 1921. So those are the healthcare services that we're supposed to be receiving, or payments, not like favor thing. So that, is something that I think will end up being a huge deal. There also was, there's been some data that's come out now from Running Bears studies, which has been the first medical studies to examine the relationship between boarding school and health status. That's funded by National Institute of Health, which has been really, I think will be very helpful, because that is going to kind of help to build the case for kind of what Indigenous people have known for a long time, that had a substantial impact on our people and has echoed, through our generations. And so, as far as, I think those are some great efforts that are happening in the community that I work in. There is, I think a lot of discussion about mental health services and substance use services becoming a little bit more, meet them where they're at, which can be really helpful, because people of color often have a reluctance to engage with healthcare providers or service providers because of our experiences in the past. And I always think, as in my experience as a nurse and an MP, whenever you're able to extend yourself a little bit further, people can see that as something that makes you a trustworthy person. You're not just there for a paycheck or whatever. You're there because you actually do care. You really want things to get better for a person. So that's kind of locally, that's some things that are going on. And, I think that I hope to see those things continue past just naming the issues. I think that's been a problem for a long time. And so when I think about, talk about racism, experienced, by Native American people, I feel that the most effective way to summarize that is that the racism we experience is it because we've been cast as the bad guy in the story of this country. The story of the United States and Manifest Destiny and all of that. The protagonist, all of that is always Native people, or is a way somehow and causing trouble somehow, and we're the bad guys who shoot at John Wayne and things like that. And so I think that and there's a lot of omittance of a lot of the history too in between things, and a lot of downplaying of what I think a lot of people are afraid to admit the full spectrum of what happened to us as being an attempted genocide of our people. One that was so egregious that Adolf Hitler used it as inspiration for what he did, actually. So that kind of being like the bad guy, and then I don't know if that sets bias maybe within people, and so whenever they hear about these problems on the reservation or with our people, I think that many people think, well, this is like the self-caused, and there's a lot of assumptions that are incorrect too. Like I said about like the Indian Health Services thing, about I can't tell you how many times I've been told I don't pay taxes, and that's not true. If it is, I'd like to get all that money back because I've paid a lot in taxes, that we don't have to pay for schooling, things like that. Those are all incorrect. But those kind of assumptions and incorrect, information does kind of leave, I think, a lot of people, including healthcare providers, for sure, to have a lot of assumptions about Native people that are incorrect. And that is something I've encountered while working with Native people and hearing their recanting of experiences, as well as just I know one thing I'll say is I get I think that is kind of a microaggression is for lighter skinned Native, like me. It's like, well, you don't look like an Indian. Well, because I'm not like an Italian guy that's been painted with brown makeup chewing off the back of a horse, or what is your description of what an Indian person, Native person looks like? Because I mean, my ancestors are from up here in the north, so genetically there's no reason. A lot of us are light skinned, but for that, because I don't look like a typical Native person, I've had a lot of coworkers talk and say terrible, terrible things about Native people around me, and not, be aware that I like joke around like the undercover Native. But so that's a kind of the brief synopsis. As brief as it could be, this is very like deep topics and very like broad discussion, again, because so much of the history and background of things has been so minimized and deleted, that it is kind of like a lot to explain. Is there a background on that? But
Whitney, thank you so much. There were so many important things in what you said, and I just want to highlight a couple of those things. Maybe starting from the last part. Yeah, I don't think anybody wants to have people comment on whether they look like one of our identities. Like, as a mixed race person, I always have people from the white and Black community weighing in on how Black I look, and it's just unnecessary. So I completely related to what you said about that, and I would say that definitely constitutes a microaggression. But some of the things that you were saying related to boarding schools, like, this is something that's coming out in our news. We're hearing more and more stories about the uncovering of this horrific thing that has happened in our history, including the graveyards that are around the boarding schools where Native children were killed. I mean, name an elementary school that has the graveyard of the school attendees there, right? And so one of the things we talk about with health equity, one of the many things that impacts health equity is communities who mistrust the healthcare system. And what we're talking about here with boarding schools, and again, many of the broken promises and treaties and policies that the US government has made with different Native peoples, this has created a very rational mistrust. And this is going to take generations for us as a overall community to rebuild that trust. But Whitney, what you were talking about, your role as a nurse practitioner, like a lot of people in this work will say, I'm not sure what my part in all of this is. How can I make health equity better? Well, there are multiple ways. One, in those interactions that you're having with your patients. And that's one of the things that you do really well, Whitney, is really exemplify cultural humility and how important it is to authentically engage with our patients and our communities. And then the other thing is really understanding the policies that have got us to these health disparities, and looking at the broken policies and the existing policies that impact the health of many Native communities is one of the ways that we can understand structural inequities, how this is structural, and that until we address those structures, we can't move forward. So I'm looking forward to hearing more about your perspective and the things that you're doing, Whitney. Thank you, thank you, thank you. Next up, I'm hoping that Dr. Boston Leary, that you will talk with us for a few minutes about how the ANA is prioritizing addressing racism and advancing health equity. What are some of the current efforts that the ANA is focusing on? And maybe what are some of the things that the ANA is even considering? I mean, I know that a lot of us, across organizations, across geographic areas, are sort of brainstorming and trying to figure out how do we move the needle forward. And we would love to hear how the American Nurses Association is doing that.
Thank you, Piri. And Whitney, thank you for that story as well. It's your vulnerability in sharing it, and could see the passion coming through as you were explaining and sharing, reviewing your synopsis, as you called it. It's just heart pounding. So I'll start with the Future of Nursing report, and where there was a direct call out in terms of what we need to do, what particularly nursing associations, and having a collaborative effort to address a lot of these issues as it pertains to racism in nursing and health equity. And the call out was specifically about supporting nurses to advance health equity, to ramp up expertise, public health training, diversity in nursing schools and the profession, innovative education financing, and supporting academic progression for disadvantaged students. So in January of 2021, which feels like eons ago, the ANA worked with a number of institutions and associations to do just that. And we launched our Commission to Address Racism in Nursing on the 25th. And this is work that's being led by the ANA and the National Black Nurses Association, the National Coalition of Ethnic Minority Nurse Associations, NCEMA, and the National Association of Hispanic Nurses. We also have a number of other participating organizations, and some of the attendees here are a part of these organizations. We have the American Academy of Nursing, the American Pacific Islander Nurses Association, the American Association for Men in Nursing, Chi Eta Phi. The list is pretty long. National League of Nursing, and we set up a vision to really address the fact that the nursing profession should exemplify inclusivity, diversity, and equity, creating an anti-racist praxis and environments. And our mission being setting the scope and standard of practice that nurses confront and mitigate systemic racism within the profession, and addressing the impact that racism has on nursing and nurses and nursing. We have three main goals: engage in national discussions, develop strategies to actively address racism. This is where we put our money where our mouth is, and not just be happy with just meeting, and also develop a scopes and standards to use for organizations and institutions to use as a framework to create a roadmap for action. Now, one of the first things that we decided to do was create a definition of racism in nursing, because with all the research that we did not find a definition that we felt was suiting or suitable for our work. So with our scholar in residence, Dr. Ramey Alexander, we were able to develop a definition. And the definition goes like this: assaults on the human spirit in the form of actions, biases, prejudices, and an ideology of superiority based on race that persistently causes moral suffering and physical harm of individuals and perpetuates systemic injustices and inequities. Once we set our definition, and it was agreed upon and approved by the commission, we started to do some listening sessions. And actually some of this was concurrent work. So the listening sessions that we conducted with a number of nurses, we did an open call, and it doesn't matter what race, color, creed you are, just come. And we heard a lot. We heard comments, and these listening sessions were conducted between February and April of 2021. And we heard comments such as these: nursing can be the most racist profession outside of law enforcement. They've heard comments from professors in nursing programs that Black girls don't make it through nursing education. We had someone recount a situation where she was told that people like her doesn't get anywhere, and nursing has not been particularly safe or uplifting for them. So that's just a snippet of some of the things that we heard on the qualitative side. And then we conducted a study, a quantitative study, to understand the broad landscape in terms of, okay, you know, what can we really nail down in terms of not real data, because qualitative data is real, because I'm a qualitative researcher, but we wanted to put some numbers to the stories So we did a national survey to understand racism in nursing. It was launched in October 2021, and we received over 5,600 respondents. Now we did get more, but because we didn't get full respondents from everyone, we had to curtail it down to folks that completed the entire survey. And we heard that 92% of Black nurses have experiences of racism in the workplace, compared to 73% of Asian nurses, compared to 69% of Hispanic or Latinx nurses, and compared to 28% of white nurses. But overall, what was really concerning to us is that over 75% of Black nurses say racism has impacted their professional well-being. And in a lot of cases, from what we heard with some of the emotional testimonies, dare to say personal as well. In that survey, we also heard some feedback about people living in constant fear. These are our nurses that are supposed to take care of patients, feeling worthless, feeling anxiety, and giving up on applying for higher positions, being called the N-word by multiple patients on multiple occasions, having assignment switching because a patient may say that I don't feel comfortable with this nurse. Those are all things that are happening today. And we actually heard stories that would actually, if you really close your eyes, you would think that these are things that are happening in this, prior to the civil rights era, that are happening in some of our communities. And these are not isolated to our rural communities. Some of these are happening in communities that are very diverse and supposedly very progressive, right? So I want to make sure that there's an understanding that this is pretty much everywhere. Now, we are now moving towards creating a foundational report, and the report has a number of sections to it. The first section is a historical context of racism in nursing, what that looks like. And we are planning on putting it out for public comment. We actually have, and it went out for public comment between the 18th of January through Valentine's Day, February 14th. And our goal is to publicize this report before the end of the month. Part of the report also includes contemporarily how racism shows up today, because racism today is cloaked in a number of different ways, right? It's the invisible enemy. It's not the typical very much in your face type of reaction that you get or confrontations you get. It's sometimes hidden. It's a concealed weapon. So we wanted to create a report around how racism shows up in nursing research, how it shows up in practice, how it shows up in policy, and how it shows up in education. So please look for that report. It should be coming out soon. And we will do a broad launch so you would know on social media and a number of the channels for everyone to be able to review that. And thank you to everyone that also gave us feedback on that part of the report, because we put that out to public comment as well. So we've been doing Project Echo sessions where we've engaged a number of thought leaders on racism in nursing to just give ideas and thoughts around how it's almost like an M&M, where you would talk about how racism shows up in an experience or some framework around how to address racism. And then we engage in small group work discussions around case scenarios. What would you do? And the scenario we put to the room, and then we come back and have a final report. So those are still ongoing, and they've been very well attended. So what's coming up? We have a quick video series that's coming up to educate on anti-racist behaviors. And the other thing that I want to share is that we did release a report also in the form of an infographic on the top 10 ways to address anti-racism in nursing. We will continue our Project Echo series as well. We plan on doing a virtual forum on racism in nursing, and we also plan on releasing another webinar that will be free to everyone to attend to understand how racism shows up. I'll also close with this. The ANA also recognizes the role that it played over the years ago and continues to in terms of racism in nursing. And one of the things that we've been working on that we really are excited, don't want to say excited about, but we're hopeful that it will help with how we can understand and be, I guess there'll be an appreciation of the apology of what role we played. And we plan on releasing that very soon. We are going through our board and it's been through our board. We're having membership assembly in June where we're going to release it and discuss it with our state affiliates. But this is a document that we feel and we hope would help with moving us forward, where we acknowledge our wrongs. We give examples of some of the wrongs that we've made. We talk about Mary Mahoney, and Mary Mahoney, as much as we hold her up, Mary Mahoney was never able to practice in a hospital, even though she trained there. And the only time she was able to go back into a hospital is when she was sick herself with ovarian cancer and she needed care and she was given care. Otherwise, she was forced to work in the communities, which I'm sure a lot of our nurses of color would have still done, but the opportunity wasn't there. And it had socioeconomic impact, a number of other harms that they incurred. And that's all that we cover in that report. So we look forward to releasing all of these reports really soon that shows the work that ANA is doing independently, because the reckoning document is ANA independent work. But the foundational document in terms of how ANA, how racism shows up in nursing is a report from the commission of all these institutions that I mentioned, and then some, because there's so many more. So that's my report.
Thank you, Dr. Boston Leary. I just have to say how excited I am about the work that ANA is doing. There are so many things that are just so spot on. One of the things that you talked about early on was the degree to which you are partnering with other professional organizations in nursing to move the agenda forward. And I would like to say that in the past, because institutions haven't prioritized anti-racism, DEI, there were always things happening on the periphery. And it was almost like everybody was doing things in silos. We weren't able to have that collective power of innovation and working together. And I think the ANA is really modeling how we do that, such that, we're reinforcing our efforts, but we also have our unique, as individuals, but also as individual organizations contributions. And, I am such a fan of mixed methods research, and I'm so excited to see the report that you have. And this is leveraging the power of ANA to get a sample size of 5,600 participants, across the country, and combining that with really impactful qualitative data. This is not new data that our Black nursing students feel like they're not welcome into the profession of nursing. The idea that nurses can be, as racist as law enforcement, wow, that is a statement, because I don't think that's how nursing or nurses view themselves. Yet, there are health disparities that cannot be accounted for other than there are interactions happening between, healthcare providers and patients, nurses included, that are causing this disparate outcome. And I wanted to say that, as I said, I'm really excited about the report. Where can we go to just make sure we don't miss the report? Should we be checking on the ANA website, or where should we be looking for some of these resources that you mentioned?
Great question. So we do have a web page on our site about racism in nursing, and I'll put that in the chat so everyone will be able to access that. And when we do have the report published, and we actually plan on publishing it on Mary Mahoney's birthday, but you know how we are as nurses.
Yeah.
It just wouldn't have the editing, and I own that because some of that came on my end too from my team. But we will definitely make sure, because we want everyone to read it and we want your continued feedback. We want it to be your report. It's not an ANA report or NBNA. It's our report. So we want to make sure that it's something that everyone could be proud of and be a part of in disseminating as well.
Wonderful, wonderful. So just going back to the chat room, a lot of people are posting really interesting links, so be sure to go there. And then last thing I wanted to say in response to your presentation was thank you for modeling the apology piece, I think that this is something that is going to need to be done collectively across institutions. But, you know, acknowledging things that have been done or things that haven't been done that have contributed to disparate outcomes is the very first step in being able to move forward. And again, regain that trust that may have been lost through previous activities. And there's so much power in the ANA. And again, I'm just so thankful that that y'all are doing the work that you're doing.
Yeah, thank you for saying that, because I do want to hit on that point too, because I think Dr. Denny Richmond mentioned this, where we didn't want something performative or lip service to setting up the apology, and then the work, we did the work and we are continuing to do the work, and then the apology is going to come. Because we wanted to make sure that there was weight behind it. It wasn't, and there's been too many examples of lip service. So,
Yeah.
and we have a lot of reason for people not to trust that we're not going to do the work. So that's why we wanted the work to get going. And yes, that document is fully about storytelling, humility, and apology to all nurses of color in terms of what ANA has done. And the fact that there are so many harms and ills that we can't fix, right? Because it's been centuries old. But we want to partner in terms of to figure out how we move forward. That's the goal here.
I love that. So it's an apology that has some substance to it. I was thinking about Whitney Fear talking about the boarding schools, and you know, it's not enough to simply apologize, but when the Pope talked about accountability from the Catholic Church for the boarding schools, like I felt this sense of hope that maybe we can move to the next place of healing and reconciliation with some of these historical injustices. So a lot of this is tying together. All right, thank you so much. Next up is Dr. Carly Zagers. Hi, it's so nice to see you again. It's been a while.
It has been a while.
I think the last time I saw you was pre-pandemic. So thank you for coming and representing the National Association of Hispanic Nurses. This is an organization that I've been part of for years, and I have so much admiration for the work that you're doing. And we wanted to give you an opportunity to talk about what NAHN is doing, like the strategic plan or the efforts that you are doing to help move forward health equity and making sure that we're addressing anti-racism in our country.
Yes, thank you so much. And thank you for this opportunity. It's truly, it's riveting to be amongst colleagues and exciting to talk about this work. And I'm privileged to be here on behalf of NAHN. And I do want to send my excitement from our president, Dr. Adriana Nava. She was actually invited to the White House, so she was unable to make it today. So hopefully I can fill some very large shoes, and talking about how we are actually going to be able to step up and make that change. So talking about what we're doing strategically about addressing racism in nursing. Well, first and foremost, I have to lean on what these ladies have said already, which is creating that change through action and enabling that bold action to take place internally and externally, and really stepping forward. Dr. Ackerman Barger, you have always empowered me individually and personally to grow in cultural humility and in this idea of what do we need to do. And the first step in that is always internal reflection, right? Who are we and what are we doing? That's the first step. And I think that is definitely where NAHN and a lot of organizations are starting, right? We have to start in that sense. And it sounds like that's what ANA is doing, and what a lot of these communities are doing is where are we in all of this, and what do we need to do about it? I think demonstrating that capacity building and empowerment through skill building and growing individuals internally is going to be a huge reflection on our strategic plan. For example, one of the first things that we've been really working on as an association is looking at our mission statement, which is the commitment to advancing the health and Hispanic communities, to lead, promote, and advocate the educational, professional, and leadership opportunities to Hispanic nurses. Hispanic nurses, that's a broad term, right? We're not homogenous. It is very broad. It's communities, it's people. You know, we think about the month that we're celebrating right now with our Asian Pacific Islanders, that's 3% identify as Hispanic. So it is truly a broad-reaching, circumference, and it's a family. And so looking on leadership development is one of our big things. In the last year, we started a leadership development series for our chapter presidents, where they learn or strengthen their educational, professional, organizational skills. Additionally, we also, for our members, have expanded our opportunities for the Latino Leadership Institute, which focuses on a leadership track and policy development. At our national conference, we're promoting leadership development again for our Latino nurses, as we're creating a sustainable pipeline of leaders who will be able to infiltrate throughout our healthcare systems and communities to lead the development of policies at the facility, academic, community, state, and federal levels, and really empowering individual voice. Secondly, I think what I'm really excited about too is partnering with the national organizations through the Commission to Address Racism, as we just heard from ANA. Our first step is really, again, internally, but also addressing by spreading awareness and knowing that this is a problem. This is not just a problem for hospitals. This is not just a problem for, Central America, the US and not Central America, pardon me, the Central US, and it's coastal, it's every corner, it's our Puerto Rican nurses. What are we doing on a day-to-day basis in order to spread awareness that this is not something that we can do without thinking about everyone? It is truly the next inclusive process. Working with NCMNA, it's been a pleasure to work with the commission, and then also NCMNA, which is the National Coalition of Ethnic Minority Nursing Associations, and working on policy that kind of goes across our voices and it is inclusive and lifts with power. A next element that I'm really excited also is that we as an association and organization are going a growth and a new leadership transition. We have a new executive director who brings expertise as a developmental, organizational, structural individual. She actually brings 17 years of international work to us to really look at that global perspective and look at globally what we need to do. Something I'm also excited about is we actually just reinstated our DEI committee as a association that focuses on ethnicity. That is huge to have a DEI, and that's not only just internally, but it also is a way to demonstrate how things can and want to be done. We need to demonstrate that. So really looking at how we're going to strengthen that internally in order to replicate that within our state level associations, within our hospitals, within our communities. I'm really excited about that. We recently just heard about our DEI committee working with our policy committee to draft a statement on racially charged violence against communities of color. Working with that demonstrated that this DEI committee is infused within our culture now, and it is not just a separate committee. We cannot have DEI being separate. It literally needs to be woven throughout our fabric and woven throughout things that we do daily, subconsciously, and bringing it forward and thoughtfully having it as a point to review our organizational policies. Speaking about that with a strategic planning, I value this very much. And again, from learning with and amongst others, is that this review and this internal dive and looking at us as nurses has to be structured. We value that. I believe nursing was built on the theoretical frameworks and models. That is incredibly powerful to have guides and reflection and intentional changes. And some of the work that we're doing, I'm excited about, is going into this upcoming strategic planning session this July at our national conference for short and long-term goals, but then also really turning over every rock and every policy and everything that we're doing. And is it what we want it to be? Is it inclusive? I'm really excited to use a tool that I've pulled from another association by Dr. Kamara Jones, Seeing the Water, 7 Value Targets for Anti-Racism in Action, and really looking at some of these tools and some of these frameworks on how we are going to do this, and not just flippantly going through the pages, really looking at those structures, really looking at this from all the angles that we need to bring forward. And I think that's what the recommendations from it aligns with the recommendations, right, from the Future of Nursing it's intentional work, heart forward work. And then finally, I think, Non, I'm very proud of this, and it's something that I stand by, and I hope that our members feel supported with as well, is that when racist acts happen in our communities, we speak up and we speak out, not just through public statements and advocacy for policies that advance health equities, but also as individuals. And that gets back to that training and really re-understanding our need for structure on capacity building, empowerment, skill building. Just saying we want to end, racism, you can't just say it, right? You have to understand the skills and the next steps and the trainings and the reflections and the evaluation of those elements too. So stepping back and really looking at all the strengths that we have as an association, and really excited about that work that we're doing. So thank you for the opportunity to be here, and we're really excited to be a part of this.
Thank you so much, Carly. And again, there were so many wonderful things that you said in there. One of the things that resonated with me and my personal experience with Non, you really talked about how you create family. And as someone, I don't identify as having a Hispanic background, but I became a member because I wanted to see what Non was doing and how can I be of service. And people have just really reached out and embraced me. And that is something that Non does really well. And when we think about that in terms of leadership, when we're thinking about who are our next leaders, oftentimes it is that sense of community and people having faith in you and saying, hey, would you be interested in considering training for a leadership position? And again, we need more folks from underrepresented backgrounds to represent on policy, in research, in education, all of these things. So Non has been doing a good job with that and continues to. You were also talking about your work with some of the other minority nursing professional organizations, particularly in CIMNA. And again, this is an example of groups coming together and having a shared goal and moving forward. And each group has its individual focus, but there's always this dialogue about best and promising practices around that. And so the DEI committee, yes, we need to have more DEI committees. I think another thing that is helpful is having a DEI strategic plan. Like a lot of organizations will have a strategic plan where there are a couple of, shout outs to DEI. But if we're really going to move this needle forward, having both a committee and a strategic plan moves it into the action area. And one of the things that can happen, Carly, you said this, looking at existing policies. A lot of times there are embedded and hidden pieces within our policy that are perpetuating disparities, and we don't even realize it. We're like, well, it's always been that way, and we've just come to accept that that's the way that things are. So this notion of looking at policies from different angles, I think is something that we can take away from this conference and make happen in our own organization. So I just really, really appreciate all of the things that you've said. Thank you so much. Again, I see lots of things happening in the chat, lots of links that are DNP of color. I don't know who's running that, but you're putting all kinds of great links in there. Keep them coming. Okay, so the next question is for Dr. Ann Gakumo. And the question is about holistic admissions. So what is the value of holistic admissions? And based on your experience in implementing holistic admissions, what have been the strengths, what have worked really well, and what have been some of the challenges that you might have experienced related to implementing holistic admissions?
Thank you, Piri, for having me. And I will say that it's really great to hear all the wonderful things that the other panelists had to say. I'm thinking specifically about NCMNA, and I credit them 100% for why I went back to get my PhD. So I really have a close connection with them. So at the UC College, College of Nursing, we started developing our holistic admissions process back in 2012, so about 10 years ago. And it came about at our college because we were challenged by our dean, Greer Glazer, at the time to really take a look and re-examine our current admission processes. And I believe her stance was, can't we all agree that it takes more than a test score and a GPA to be a great nurse? And so she was the driving force behind looking at things differently in order to increase the diversity of our students. And prior to that, at least in the undergraduate traditional program, we were looking solely at GPA, SAT, ACT scores to determine acceptance. So we basically had a list of student applicants. We started at the top of the list and worked our way down until we met our numbers. Now, every program in our college at the University of Cincinnati, from traditional to graduate to doctoral, uses the holistic admissions process to some degree. And we look at a wide variety of metrics and attributes to make sure that we have informed and mission-driven decisions about our future students. So I think it's important to note that around the same time this was happening in our college, we were moving towards a direct admit into freshman year. Before we had more of a pre-nursing school model, which I think is still pretty common. So there were these two things going on at the same time. And I think it shows our strong commitment that, if we're doing this when they come in as freshmen, or looking at this process, that we are going to commit to these students, we are going to graduate these students. So some advice that I would give, first and foremost to colleges and schools of nursing that are looking to embark on this journey is to, of course, educate yourself on the process. I know for us, we had workshops. We were fortunate to have administrators in the college, Dr. Glazer. I'm thinking also of Dr. Karen Bankston, who had some published work in this area. In terms of, just a few elements to include, an admission mission statement that is rooted in your school's larger mission statement. It should specifically speak to, what you're doing, why you're doing it, how you're going to do it with regard to admitting more diverse students. A group of our faculty worked together for a whole year to answer those questions. And to really put their all into this. It's also important to determine, what attributes that are unique to your college or school that you would look for in potential candidates and how you're going to measure them. Not only that, but how you're going to weight them in relation to the more quantitative metrics. In terms of successes and challenges with holistic admissions, I think one of the biggest successes is that we were able to admit students that we would not have otherwise captured had we not moved to the holistic admissions process. Again, we were just looking and going down a list, but it's interesting. We were looking at a recent cohort of students that we admitted under the holistic admissions process, and we compared that to what would happen if we had our previous policies in place. And if we were to use the same metrics that we did before, a significant number of those students would not have made a cut. So I think that's a huge success. In terms of challenges, it is more work. It's easier to get the applications in, rank everybody by test score, GPA, call it a day. That relatively takes little effort to do. However, going through reading essays, recommendation letters, looking at extracurricular activities and judging candidates on those characteristics that you're looking for. It takes a lot of time, a lot of energy, a lot of effort. Faculty and staff are involved in this process in interviewing potential students. So it's a lot to pull this off. It's rewarding, but it would be a major transition in terms of time and effort. Another thing I would say is that holistic admissions are only effective as the people who implement the process. And this is more, I would say a recommendation rather than a challenge, but number one, everyone that's involved in this process should have ongoing DEI education and training so that they are aware of their own biases, how to address them, and so that they don't create additional barriers or otherwise, thwart the process. And, to be clear, we know we all have biases that can potentially play a role during the admissions process and interview process. In addition to DEI training, implicit bias training, another thing would be to blind interviewers to the academic metrics so that they don't know where these applicants stand in terms of their test scores or GPA. And a third thing I would say is, consider giving equal weight to, experiences, attributes, and academic metrics. And this is probably a debatable topic. Each institution has to make that determination for themselves. And then lastly, I would say to make sure to ensure diversity in the composition of holistic admissions committees. Now, there may be issues in terms of not having an adequate pool of diverse individuals, from which to draw. So just be open to looking outside the college or school to other health professions, faculty, clinical partners should also be involved in this process because, at the end of the day, we as institutions of higher learning are delivering a product, right? A student who's completed their degree, passed their boards, most of them will be going to the clinical setting. So for sure, we need to include our clinical partners. Available resources. I've heard over the years, oftentimes when you're speaking about holistic admissions and recruiting and retaining more diverse nursing students, many will say, well, we don't have adequate resources. We don't have the support or the tools to help make these students successful. And in my opinion, I believe that is displacing responsibility a bit. Now our resources and student support important, absolutely. But we can't all have federally funded nursing workforce diversity grants. So what do? We have to think outside the box. We all need to take collective ownership in these efforts and not put the onus on a select few. We need to reach out to our alums for mentorship support. Another would be, tap into our community for additional resources. But even before that, we need to know our communities and be engaged with them in these efforts. I will add another question that is often asked is, how can holistic admissions be implemented without compromising the quality of our nursing programs? And, to that, I would say we need to look at where our priorities are as colleges and schools of nursing. Do they lie solely on having very high NCLEX scores and pass rates for the first time? Or do we prioritize diversifying our workforce to reflect the populations that we serve? If it's the latter, then leaders in academia, again, need to take ownership of these efforts. And if it's the former, we really need to re-examine ourselves because the research has been very clear on the benefits and advantages of a more racially and ethnically diverse workforce. So looking towards the future, it doesn't just stop at holistic admissions, right? So once we get our students in the door, then what? We need to be mindful of how holistic admission ties to the larger teaching mission of our institutions. And we need to make sure that once we get students in the door, we as nursing educators can foster those attributes that we look to find. So if health equity is an attribute that we value highly for our students when they apply to our programs, once we admit those students, we have to ensure that equity is reflected not only in our course content, but also in our teaching pedagogy. And we need systems level thinking of how we onboard faculty for their courses. Administrators and program directors, I think a lot of times make assumptions about what they think faculty know. And so, gone are the days when you have one education module on equity or one education module on social determinants of health, right? It's a really exciting time for nursing right now in terms of nursing education going through a huge transformation with the new essentials and in terms of us reexamining our curricula. And so I think, it's important to think about, the full trajectory of our students' academic journey from the beginning of the holistic admissions process to their educational experiences and how that's interrelated. At our college right now, Pierre, you mentioned before about having a specific DEI strategic plan. Well, right now we are going through that process, very, very focused in terms of, looking at what our DEI mission is, what is our vision, and, who are our key stakeholders and constituent groups that are involved, and how does that tie into the larger tripartite mission? Because again, it can't be like a side thing. It has to be interwoven, throughout. So I'll leave you all with this. It's interesting. I was looking at a recent paper. It was a perspective paper, so it wasn't a study. It was done a couple of years ago in the journal, I think it was 2020, the Journal of General Internal Medicine by Anderson and colleagues, that challenged schools of medicine to use the admissions process to address structural racism in medicine. And what they recommended is that one way to address racism is to stop admitting student candidates with racist beliefs. It sounds really bold, right? And so, that they said that determination could be made during the admissions process, right? During interviews. I mean, think about it. During the holistic admissions process, we're already assessing hard to quantify attributes that we want our students to have. So what about the attributes that we don't want them to have, right? And I'm thinking about, as I'm talking, I'm thinking about the complexities and some of the legalities of this, but it could be, as simple as giving case scenarios and asking candidates to respond. We do it for other attributes. So, we can evaluate, for example, given an applicant's response to a scenario, if they lack empathy, right? So I think, along those same lines, we can also evaluate whether a candidate demonstrates a commitment to diversity and inclusion based on their responses. And, it's still amazing to me to read current literature and find research done to show many longstanding racist and discriminatory beliefs that exist among healthcare providers and nurses. And so I'd like to challenge us in nursing academia. We know that structural racism exists in nursing. We know this. And, how are we as nurse leaders actively trying to address it? Moving beyond diversity and inclusion statements, those are important. But how are we dismantling racism on an institutional level? How are we reexamining and challenging existing policies and practices that have been in place for 100 years or more? So we created these structures, and so we can dismantle them. So thanks for the opportunity to come and speak. It's really encouraging to hear all the work that's been done. And I look forward to having more discussion.
Wonderful. Wow. I was instantly in my hat of being chair of our admissions. Lots of really good reflection points there. Everything to having mission-driven admissions. So this talks about really stating what it is the school wants to do. What are we trying to do? And then what are we going to do with our admissions? And then like you said, having that strategic plan that will follow up. This notion of stop admitting students with racist values. I had to write that down and underline it. And I'm like, yeah, how do we assess for that? And that's rhetorical in my mind at the moment, but just a really interesting thing for us to think about. There are some questions that have been coming up from the audience as you've been sharing some of this really important data. One of the questions is, as people are thinking about holistic admissions, are you or do you know of schools that are bringing students in to participate in holistic admissions?
That's a good question. I think what has been our custom is that, and honestly, let me just say, I think it's a great idea. Ordinarily, as it stands right now at UC, it's primarily faculty driven in terms of making decisions. Although we do include staff as well. So along this process, our staff have an opportunity to interface with potential applicants and give their assessment. I think it would be something that would be wonderful in terms of looking at challenging the way that we currently do these practices, looking at our student leaders, because again, they are who we turn out to the world, and really want to serve as examples for the students that are coming in the doors. So it's not something that we currently do, but I do think that it would be a wonderful idea to explore that.
Thank you. Yeah, that got me thinking as well. So whoever asked that question, we appreciate it. Just a reminder, don't forget about the chat. Vernell DeWitty put in a link to the Holistic Admissions Toolkit that is on the AACN website. There's also a question out there: who's holding academic institutions accountable to improve diversity in nursing school? Not something that we can address at the moment because I want to get to Joan Gallegos, but that is something that we should think about, is that notion of accountability and how
I will, if I can, just briefly answer. As we're going through the DEI, we are slow on time, but we do have an accountability retreat scheduled. So that accountability factor is very important. So those are some things that we'll be discussing as we move forward with our DEI strategic plan. Thanks.
Yeah, interestingly, I just was part of LCME, which is the medical side of that, and their accreditors were asking questions specifically about admissions, and just got me thinking about whether we should be doing that in nursing or not. Joan, it's lovely to see you. It's been several years since I've seen you, and I'm happy to see your face again. Our question for you is, how has your Action Coalition been addressing structural racism, and what can other action coalitions be doing to replicate your efforts?
Well, thank you, Perry, and it's good to see you, and thank you for having me today. I'm with the Utah Action Coalition, and we really have addressed this topic in two big areas. One, we have a Nursing Innovations Grant, which I'm going to talk about in just a moment, that addresses this structural racism. And then secondly, we have a pretty cohesive and thorough Action Coalition plan that we developed at a summit in December that really outlines the thought perspectives and the actions that our healthcare leaders in our state want to address in terms of the priorities of the National Academy of Medicine on the Future of Nursing Report for the next decade. And of course, many of those priorities deal with structural racism. So I'm going to talk about those two main topics today. So let me get into first our Nursing Innovation Grant that was awarded last year. And I do, encourage Action Coalitions to apply for these opportunities that do come periodically from the campaign. We've had 2 nursing innovation grants, and they were able to build on diversifying our nursing workforce. So our current nursing innovation grants really has 2 focus areas. One is we're working on the pipeline of future diverse nurses in Utah. And we have a pretty abysmal record here in Utah for our nursing workforce being very female, Caucasian, and for instance, let me just give you this example. Only 2.2% of our workforce is Hispanic, contrasted to our largest minority group, which is Hispanics in Utah, which comprise 15 to 60% of our population. So because our grant, is limited in the scope of nursing innovations, we really are focusing on bringing more Hispanic students into our nursing workforce, since that's our largest minority group. So we've been actually meeting with high school and middle school students in our most diverse school districts in Utah, which are along our Wasatch Front, our most populated region, like Ogden and Salt Lake City. We've been meeting with our technical institutes in these school districts. And to date, we've probably met with about 250 diverse students in CNA classes and that are studying to be medical assistants. And just out of interest, when I start these classes about the nursing profession, I would say a good 3/4 of the students in these classes raise their hands that they do want to continue as nurses. And many of them are very diverse in their background. Of course, we really need nurses across all sectors. So we're glad to, get anyone interested in nursing. But we've really targeted our education to those districts that have the most diversity in them. And of course, the students that we are working with, struggle with the social determinants of health, poverty, housing. And I'm sure, other regions, we're just seeing our housing skyrocket rent. So that's really been a problem for our families in our diverse neighborhoods. But one of the key things we found through our work is that we really are picking up some key perceptions of bias from the teachers and the counselors. And it's, the counselors, they're very overworked with high caseloads, but they tend to discount our minority and ethnic high school and medical students, like, oh, don't put your efforts there. They probably, won't be interested. They tend to focus on more the white upper middle class students. And so we've really, had to work at addressing these biases. And I'll tell you, they get very defensive. And, our teachers too, like I'm just gonna give an example of a recent class I taught. The teacher actually said, well, you can see, Joan, by who is in the class that they would struggle. Well, no, no, just because, they're Hispanic or from an inner city school district doesn't necessarily mean that, but this is the bias. So one thing our Action Coalition is doing is not only identifying and calling these out, but we're going, to the high school science teachers and high school counselors to their conventions that are coming up in the next month to actually talk about implicit bias. And we kind of have to be a little careful how we do this because they can get mad when you point these things out to them. And I have a doctoral student that's working with me from the University of Utah who's just incredible. She's Hmong and has a wonderful story of how she overcame a lot of hurdles to become a nurse. But we're actually going to use her, as a picture of her and ask people to think what do you think she is? Well, being Asian, they might say, oh, she's probably techie, is, good at, technology, math. Well, it's just the opposite, so we're going to kind of approach it softly at first, because we don't want to get, this big pushback, that we're jamming this down their throat. But that really needs to be something addressed. And our Action Coalition will have continuing work on this. These are the biases that are going into identifying our future nursing students. And they're not healthy. So one of the other things we are doing with our grant is to involve Holy Cross Ministries with Catholic Church with our families, because the Catholic Church is very an important influence for the Hispanic population. So we have a big partnership with them. And also in our work, Carly, you'll like this. Our Action Coalition previously funded our UNITAS in Utah and was the backbone organization for our local chapter of National Hispanic Nurses. And we're taking mentors from that chapter. So when I go to these classes, they're these students are right at this transition point. Now they're graduating as a CNA, they've got this, or, and now they're going into the workforce. So that teacher is no longer there to help guide them. So we're linking them with mentors with our UNITAS in Utah chapter, which has been a very positive thing. It gives a real world kind of work that our local chapter can do. And, I want to say our local chapter, UNITAS in Utah, we really had quite a sizable group of Hispanic nursing students that came and joined. One thing we learned by just listening to them was, and Piri, you hit this along with our previous speaker, about they identified the microaggressions that they're experiencing, not so much from teachers, but from their fellow students. And, that was very, very hard for them. And we have a very good relationship with our deans, with all the schools of nursing. We've been able to bring that information back to them and, tell them this is, it's just not getting your faculty, some implicit bias, but, our student bodies are having these issues. And so the mentorship, I think it's important that you just don't do a one shot with them, that you can have a continuing relationship, because there's hurdles, whether it's nursing school applications, financial aid, whatever. And then in some of our previous work we've built on, we actually worked with our nursing deans on their admission processes, like our previous speaker talked of. Some of them are implementing whole admissions, yay. But what do your mission statements look like? What does your website look like? Does it have, diverse students on it? And we talked about actual implicit bias training, with faculty too. And it's interesting that when we first brought this up, it's like faculty, we heard collectively was like, no more of this training. We've had enough. Well, here is where you use data as an Action Coalition. We couldn't really, we were getting pushback, okay? No more, no, we've had all this. Well, You know, we do surveys every 2 years with our nursing workforce center. And this is something, you know, our Action Coalition helped to a data center set up in our first SIP grant. And you know what? We were showing that our representation of Hispanic nursing students had gone down after all this work we had put in. Well, you know, you can't really argue with data, can you? So if it was 2.3% 2 years ago, and now it's 2.2%, representation of Hispanic nurses in our workforce, we certainly still have a big issue to work on. So, you know, do use your Action Coalition and your nursing workforce data because that's where the rubber meets the road. These are the outcomes. They're not moving, and we need to address this. This is the reality. Another quick thing we did, which backs up, I believe, what Dr. Katie Boston Leary was talking about. Our Action Coalition, we're, you know, a small state. We, you know, have limited volunteers, and they have many, many other work jobs and things to do. But we used our Jonas Scholars at our colleges. We had one Jonas Scholar work with us as the Action Coalition to identify barriers of first-year diverse RNs. And that was pretty telling. Quickly, I know we're getting close on time. 50% of our nurses diverse nurses considered leaving the workforce for reasons related to cultural environment, staff, or resident issues. 30% reported feeling uncomfortable at their workplace due to race, ethnicity, etc. 30% did not feel that their contributions were valued, and they were not. We spend all this time reaching out to our diverse high school, middle school students, getting them to school, and then they go, you know, your first year and reach these barriers. So you really got to look at this through a multi perspective as an Action Coalition to address these barriers. And let me say, finally, with our Action Coalition plan, we did a multi-sector voting on it. Our first priority was nurse well-being, which is not surprising. 80% of our nurses and healthcare leaders saw that as a big problem in Utah. But the next big issue was educating our nursing students on health equity and social determinants of health. Third is with our workforce. So right now we have a 6-month plan, an annual plan, a 2-year plan of how we're going to make progress in that. We're just starting on it right now. We actually done an environmental scan of what the social determinants of health and health equity looks in our curriculum all across our nursing programs and in our large workforce areas in the hospital and long-term care. So we'll see what's there, and then we'll reconvene, see what needs to be there, and make some changes. Basically, persist, call it out, and I think work on that pipeline. These aren't short fixes, but you've got to address those barriers in our future nursing students coming up. We have finally a middle school camp we're partnering with the University of Utah College of Nursing to bring diverse middle school students to the campus and get them exposed to things. So that's the end of June for a couple of days. They'll be actually up at our campus. So thank you for the time that I could share some of our practical efforts, and I appreciate it.
Thank you so much, Joan. Really appreciated that. Your talk complemented Anne's talk about holistic admissions. I mean, she made the point that we need to do this admissions process, support students, but you're talking about the pipeline beforehand, which is really great. I love the idea of going to CNA classes and MA classes and talking with students. Your insight about the counselors and the bias that may be happening, you know, brings us back to this notion that the unconscious bias training is ongoing work. And I heard you say that people complain about having to do that work. And it's like, you know what, we'll stop doing CPR when people stop dying. And we'll stop doing unconscious bias training when people stop having
Exactly.
dated ideas, right?
And
So
our metrics aren't improving. So,
Yeah.
you know, obviously we've got to keep doing something.
We've got to
about
keep
something
doing it.
different.
Yes, yes. And as somebody that does this all day long, I've yet to be at a unconscious bias training where I didn't refresh something, dust something off, or learn something new. So this is ongoing learning that we all need to do. And there was a question. I'm sorry, we don't have time for a lot of question and answer. All of you had such good talks and we've had good conversations so far. I'd hope to ask multiple questions, but there was a question about how do we bring more white people into this work? And, you know, I think that it's important for white folks to see that there is a spot at the table and that allyship is really important and that we do need to do that constant work. I mean, no matter what your identity is, we have preconceived notions in our head. I'm not sure who said it. I think it was you, Jen, that you cannot predict how somebody is going to be as a nurse, a healthcare provider, or anything based on how they look, right? That just is not something that can be done. And yet we have all kinds of stereotypes that are running through our heads. And just one last thing, and then I'm going to hand it back over to Soren. Somebody in the notes was asking what the difference is between DEI and anti-racism. And I just want to share a quick little thing that I feel like in my work over time, that when I use the terms DEI, that in some ways they're euphemisms. I mean, they each have their own very distinct definitions. And I think everything is part of getting to improved patient outcomes. But previous to the killing of George Floyd, whenever I used the term anti-racism or racism, it was like the conversation would shut down because people just couldn't hear it at that point. So anti-racism is a very specific piece to diversity, equity, and inclusion. And it's really hard to move the needle forward without addressing that particular thing. And it doesn't mean it's at the expense of other areas of bias, but it is a really important thing. So thank you to all of our panelists. I honestly could spend hours and hours with each of you and feel like I didn't have enough. But since we do have a schedule today, I'm going to hand it back over to Soren to close us out.
Thank you, Piri. Another powerful conversation, a lot of great resources, comments happening in the chat. I want to just check in on our agenda. We're right on track. Let's take a look at where we are. We're going to get into just a few closing statements. I want to remind our action coalitions, while our larger summit ends at 4:30, we are going to be convening at 4:30 for our action coalition kind of planning. All of this amazing discussion is going to culminate in some real actions for everyone, measurable actions as well, because we want those dashboards. So with that, I'm going to turn it back over to Sue and Susan, who are going to say some closing statements, and then we'll do some additional wrap from there.
Thank you, Soren, and thank you so much to the panelists for your thoughtful insights about how we, as a nursing field, can address structural racism in a more diverse and inclusive nursing workforce to achieve health equity. It just made my heart sing. The panelists were amazing. All the work that is going on, you know, I'm just so happy to be part of this movement. Just wonderful. These conversations are all a crucial first step towards dismantling structural racism. The next step is really looking both within ourselves, like every one of the panelists has said, and within our workplaces to take concrete steps to truly become anti-racist. Talk must be followed by action. How many times did a panelist say that? How many times did it show up in a chat? We must be the change that we want to see to dismantle structural racism. I think my favorite quote was one that was it Dr. Mix or the Colonel put up about Arthur Ashe. I just love that quote. The Campaign for Action will continue its work to build a nursing workforce that reflects the communities it serves, and it will create new resources and collateral to help the action coalitions and stakeholders achieve health equity through nursing. That's our goal. I plan on following the campaign's work closely, remain involved, and I look forward to continuing to engage with many of you. And now let me turn things over to Susan. Susan?
Thanks, Sue. That might know if that's the last time you're turning something over to me. I don't know. I'm just sort of feeling that. Wow. So as Soren just said, Action Coalition, stay on. We're going to continue our conversation in just a few minutes, so don't go away. But I do want to take a moment to thank some people before we lose our people that are not part of the Action Coalition staying on. So there are many people to include. I'm just going to do some broad things. Our educational associates, the historically Black colleges and universities, Hispanic serving institutions, and American Indian, Alaska Native serving institutions that are part of our work to diversify nursing, beginning with the nursing schools focused primarily on students of color. This is, Winifred Quinn, big thing that she's been working on along with several others here, and all the nursing students that were on today. So we're very happy about that. All of the federal government associates that joined us today, the national nursing organizations with whom we work and their champions, organizations representing healthcare delivery, insurance, and retail clinics, all the nonprofits with whom we work. Remember, this is hundreds of people have been on this. So we also want to thank our summit planning team, Wynn Quinn, Jordan Green, Anna Hervada, along with several others on the team, Jennifer Peed, Mary Boyle, Aiden McCallion, Jasmine Cooper, and the whole CCNA team. And of course, our facilitators, Piri Ackerman, Barger, and Paul Leone. Wow, fantastic work, as well as, of course, all the panelists, and our consultants, Barbara Nichols and Peter Reinecke. And of course, to the folks at the Innovation Point, Soren, and your colleagues, Gabriel Mendoza and Karen Kramer. And a very special thank you to Sue Hassmiller and Robert Wood Johnson Foundation for their continuing support of this Campaign for Action. So I just want to repeat what Sue just said. I mean, wow, unbelievable. And, I just have to say I couldn't decide. It's hard. I'm trying to listen, but I'm reading this chat, which is exploding, just exploding. So thank you so much. And again, Action Coalition, stay on. And everybody else, thanks again for being part of the summit and, more important, for the whole campaign. Thank you.
And thank you, Sue and Susan, for your incredible continued leadership. I'm going to say a couple of words to wrap. We'll share just a couple resources on the screen here. The Action Hub. If you are not familiar with the Action Hub, you should be. And we are posting all of the links and resources from the chat onto the Campaign for Action Hub. So all of those resources that have been flooding into the chat from all of you will be posted and accessible, as well as a number of other resources from the summit, as well as the campaign. So really encourage you to use and access this Action Hub. We can also put a link into the chat. I haven't seen it. There it is. Thank you. And you can access it there. One final note, if we go to the next slide, in the next hour, all of you will be sent a survey asking for your reflections on our summit. I know the team that I've been working with at the campaign is constantly just trying to take feedback, make things better, and this is an important step in just continuing to kind of drive the change we're trying to drive. So please go ahead and fill out that survey. And then finally, let's just go back to our agenda. We're going to wrap up our formal larger summit now. We would like all the Action Coalition members to stay here in this session, and we will give you a 5-minute break so that you can take a little respite, and then we're going to start at the bottom of the hour, and we'll talk about a lot of resources and tools and a process where you can start to, continue to translate a lot of what we're hearing into real practical, measurable action. So take 5, and then we'll come back and we'll kick things off with our action coalitions.
Bye all.
Use the chat just like we did in the actual summit. If we go to the next slide, I want to turn it over to Sue and Susan to just provide a little more context for us about our next half an hour. And Sue, I don't think is back with us. I'm actually looking here. I see Sue still on mute and no video. Let me just see if we can get her back. If not, Susan, I don't know if you want to just provide a little bit more context for the group here about our objectives.
Sure. So thank you, Soren. And this section is specifically intended to prepare each action coalition to plan your future objectives and the immediate next steps. I mean, ideally, oh, here's Sue.
Hi there.
There you go.
Okay, I was, all right, sorry about that, guys. So here we go. So Soren, thank you. This section of the meeting is specifically intended to prepare each action coalition to plan its future objectives and immediate next steps for the 2022-2023 year. Each of you will meet soon to develop your own strategic plan. So we want you to use your insights from this summit, and boy, there were like a slew of them, to do the following 3 things. 1, define how nurse leaders and nurse champions can effectively implement the recommendations in your state. Similar exercise to what we did 11 years ago, right? Number 2, define key partnerships, priority actions, and success metrics for 2022, 2023. And 3, discuss state level accountability for implementing the recommendations. So we invite you to think about how the 4 key action items from the Future of Nursing report directly connect to your specific strategies. My colleague, Ashley Darcy Mahoney, will describe these 4 key action items now. So Ashley served with me as a distinguished nurse scholar in residence at the National Academy of Medicine during the development and release of the second Future of Nursing report. She is one of the most knowledgeable people on this report, and she has spoken to a wide variety of audiences about the report's recommendations. Ashley is also serving now as the RWJF Fellow, and she will be engaging with national nursing groups to help them embed recommendations from the Future of Nursing report in their own work. She is a neonatal nurse practitioner and an associate professor at the George Washington School of Nursing. She has worked throughout her career to advance nursing research, education, and practice. Her research has led to the creation of programs that improve the health and development outcomes for at-risk and preterm infants. Ashley is a fellow in the American Academy of Nursing, a Robert Wood Johnson Foundation Nurse Faculty Scholar alum, and was recently named a Modern Healthcare Rising Star in Nursing. So Ashley, take it away.
Thanks so much for having me today. I'm excited to be able to do a very quick overview of the report and really focus on the 4 areas of the report that I think are most important for you all as you continue to think about the campaign and where your work fits in. So this report first and foremost recognizes that promoting health and well-being for all has long been an essential role of nurses. The reason is simple, because nurses are everywhere. Next slide. We are in clinics, ICUs, schools, and on front lines of disasters. And as the largest and consistently most trusted segment of the healthcare workforce, we are well suited to advance health equity, as we just spent 4 hours talking about. The achievement of health equity in the United States should be built on strengthened nursing capacity and expertise. And this is where you all and the action part comes in. Next slide. What we need to achieve that vision, though, is more support from the systems that educate, pay, employ, and enable nurses to continue this critical work. Across the board, we need to value nurses and the work we do to keep us all healthy and well. So, at a drum roll, please, here are the 4 actions that the Future of Nursing report lays out, which I'm going to walk through in brief detail today. First, we must permanently remove barriers. We must value nurses' contributions. And when I say value, I am really talking about payment reform and payment models. This is incredibly important to think about and talk about, and we will get into the weeds a little bit on that. We need to prepare nurses to advance health equity, and we must diversify the nursing workforce. Next slide. To start, I'll talk about how we can permanently remove barriers that stand in the way of nurses at all levels and in all settings. Whether a nurse is managing a clinic or making home visits, they face barriers every day. Nurses currently face two types of barriers. Those relating to scope of practice, which can be lifted through policy changes, and we know that there has been loads of work that has happened from the Campaign for Nursing Action on this front over the past decade, and institutional ones, the ones that affect where nurses are working, where nurses are learning, and where they're training. And when we think about scope of practice, we definitely think about all of the restrictions that we've talked about that lead to worse care. These regulations and scope of practice limit competition and contribute to higher healthcare costs. I won't review all of the sort of states that have changed to full practice authority versus not, because some of them we reviewed today, like New York and Kansas. But suffice it to say that during the pandemic, we have had states expand scope of practice for nurse practitioners so that people could better access care, and that must continue and remain in place. What about institutional barriers? Nurses at all levels and in all settings face institutional barriers, and those barriers to fully leveraging their skills hurt health equity, right? They don't advance health equity. They range in restrictions on providing telehealth services to workplace policies that prevent nurses from providing optimal care. And these institutional barriers can start when prospective nurses are in school. Students from underrepresented backgrounds, people of color, those with low income, first-generation college students, LGBTQ students may need support in a number of areas as they go through nursing programs. There may be financial barriers to attending these programs, or there may need to be social and academic supports to help these students thrive. Well before the pandemic, many of our country's 4 million nurses had physical and mental health burdens tied to their jobs. And in the workplace, many nurses face institutional barriers that contribute to high burnout and hinder nurses' abilities to do their jobs well. Organizations that employ nurses do not always give the mental health or adequate resources we need, from staff to PPE to mental health resources. So next slide, please. So what about valuing nurses' contributions in terms of advancing health equity? As the committee found, the U.S. healthcare system does not value addressing social determinants of health nor advancing health equity. It's not designed to pay for this. Currently, our system is designed to pay for quantity, not quality of care, to treat existing illnesses but not prevent them, to prioritize hospital and specialty care over primary and preventative care. And this model has contributed to deepening disparities that disproportionately impact people of color, those with low incomes, members of our LGBTQ community, those living in rural areas, and many others. Nurses can help change this. As the largest and most trusted segment of the healthcare workforce, we bring immense value. But without strong financial and institutional support, our impact and reach is limited. How care is paid for can and does determine one's access to quality of care. There are two key actions for achieving this goal: reforming payment models and valuing community and public health nursing. These are some very important things that we must think about, and that I would implore you, as you continue to think through your campaign priorities and your action coalitions, to really focus on. We currently prioritize volume of care and underestimate the values that nurses bring in addressing obstacles to good health, such as poverty and discrimination, and in expanding access to care. The work that nurses do, much of which addresses the social determinant of health, is often unrecognized and undervalued. Next slide, please. Preparing nurses to advance health equity. The report's central theme is on how to help nurses carve a path to health equity. So how can we better prepare nurses to do this? Next slide. The truth is that at all levels and in all settings, nurses are not yet prepared to advance health equity for all. Preparing them to address the evolving health, social, and economic needs of their communities should take many forms. This includes transforming nursing education, including some of the accreditation topics that we were just talking about, preparing nurses to respond to disasters and public health emergencies, and fostering nurse well-being. The committee urges nursing schools and nursing education leaders to commit to dismantling interpersonal and structural racism within their own institutions. This means changing curricula that have historically focused on contributions of white and female nurses, having difficult conversations about privilege and power, dismantling long-standing exclusionary traditions that exclude some groups over others, and understanding how interpersonal and structural racism shapes the student experience. Next slide. The final action that I'm going to cover today is the urgency of diversifying the workforce. The latest data show that ethnic minorities account for 40% of the population, but only 20% of the nursing workforce. The report lays out a number of reasons for this, again, some of which we've discussed today, including cost, cultural, society, and awareness barriers that prevent people of color, those of low income, first-gen college students, and others from pursuing the field of nursing, and particularly deterring the pursuit of advanced degrees. Nursing program faculty, self-included, are overwhelmingly white and female. 90% of all nurses in formal leadership positions are white, and these faculty are often not prepared to educate students about the social determinants of health and health equity. Nursing schools must intentionally recruit and mentor faculty and students from diverse backgrounds to ensure the next generation of nurses and reflect the communities in which we serve. As was mentioned by Puri at the end, nursing accreditors can play an important role by requiring standards for diversity like other health profession schools do. Med schools, dental schools, and public health schools have this as part of accreditation. Nursing schools do not. Next slide, please. I'm just going to end by giving a plug to all the work that has been done on the future of nursing. There's webinar series that have been posted. There's a podcast. All of the report materials are there. A lot of times you can find them on my Twitter handle too, but that's where to find them. And so I will turn it back over to you, Soren.
Thank you, Ashley. Somehow you summarized a multi-100-page report in a few slides in less than 10 minutes. That was amazing. Thank you. Let me kind of remind us where we are in our process. So what we've currently sent out ahead of time are these slides, and you should all have it, and they will be posted on the Action Hub. So what you have is essentially a toolkit. This toolkit is focused on helping you convene your action coalition so you can create a plan. We've designed this toolkit based on some of the principles of collaboration. If you participated in some of the previous summits that myself and my team helped design with the campaign, you know it's very collaborative. And what we wanted to do is give you some of the same tools that may be similar to what you've used before so that you can create your action coalition plan for 2022-2023. Our recommendation is you use about 4 to 6 hours in a working session, and it could be in one session or spread out over a couple sessions. The goal is to complete these templates I'm about to share with you and walk you through by June 17th and mail and email them to the Campaign for Action at the email address you see here. So I'm going to walk you through some of the tools that we developed, or the whole team at the campaign helped develop these to give you kind of an anchor point for how to create your plan. As we go through, feel free to post questions in the chat. I'm going to spend 5 minutes on this only. You've been sent this and you have access to it. What I would propose is that you just think of any questions. We will open it up for the last about 7-10 minutes for any questions from that you want to have answered by Ashley or Sue or Susan or myself. So let me take you through what these templates are. The first is really reflecting on your successes. We saw from the survey that we did pre-summit that there's a lot of great work being done and a lot of, almost every recommendation is being tackled from the report. So we want to have you reflect on, with your action coalition, what have been your biggest successes to date? Let's celebrate our wins. Let's look at the strengths that we've applied to make change. So first is successes. Now, let's also look at what were some of the biggest challenges that we had to face. Maybe those challenges we've overcome. Maybe there's still challenges, but as we've achieved our successes, what are some of those challenges that we've needed to address or that are continuing to be challenges that we're going to need to address. So it's really setting the bigger context. So that's template 1. Go to template 2. So here's where some of the rubber meets the road in terms of really the action piece of it. So the first is looking at how to permanently remove barriers. So the question really to the Action Coalition, and distill it in as succinct way as possible. What are the biggest insights about how we can permanently remove barriers in the systems that educate, pay, and employ nurses? We heard a lot of strategies today. Leverage those. Leverage things that you know are working in other action coalitions. Leverage what's working for you already. But think about, how do we permanently remove those barriers? These are straight out of Ashley's presentation, as you can see. The second one, value nurses' contributions by fully supporting nurses. So again, looking at some of these elements around what's the biggest insights about how we can value nurses' contributions in the systems that are educating, paying, and employing nurses. And then prepare nurses to advance equity and diversify their workforce. So we're really looking at how do we move the lever and kind of make change in these 4 areas, okay? Next part of the template. This is about engagement and measurement. So we want to look at engaging strategic stakeholders. So in the first summit we did, it was really about identifying who these stakeholders could be. You might remember that template. What we want to do now is really look at who are you going to engage and how are you going to engage them to really make sure you succeed. So think about the stakeholders to engage. Look at your top 3 to 5 priority actions. I do a lot of strategy. There's a great little quote: you can do anything, but you can't do everything. It requires that you prioritize. So think about the previous conversations you will have had as you filled out those templates and identify your top 3 to 5 priority actions for your action coalition. Then look at success measures. So what are those measures? How do you benchmark progress on those priority actions? How do we get as measurable as possible? So think about what, and there's a good question in here, do what's reasonable, Wynn's comment. Think about what you can do in a year that's as measurable as possible. And think about your SMART metrics as a framework. Think about how to quantify the action you can take and the impact you can have in a reasonable way within a year. And then finally, the accountability. Are there ways you can hold your action coalition accountable for making progress? So really what we want to do is define, here's the change we want, here's how we measure it, and how do we all stay accountable to making that change happen and measuring it over the next year. And so all of these templates are really designed for kind of reflection, recognize successes, identify the current state, and then figure out what your plan is for the next year moving forward. So I'm going to just pause here. I think let's just go to the next slide, which is our Q&A. And I'm going to ask Ashley, Susan, Sue, Wynn, you've been such an integral part of our planning team. Just take yourselves off mute and turn on your videos, and let's see if there's questions that are coming in. You can feel free to type it into the chat. And Sue, Susan, Ashley, Wynn, if you want to just embellish on any other expectations you have or thoughts you have for the Action Coalitions, that would be great too.
So I'll just jump in by saying this is complete deja vu for me. This is exactly after the first report. I remember Susan and I and team saying, what are we going to do? We went to AARP. We said, we want to partner with you. We think you'd be great to have the campaign operations there, but how do we do this? And it's the same process. Everyone around the country wanted to get involved. There was so much demand. Remember that, Susan? There was a lot of demand. What can I do? What should my state do? What can I do? What can my school do? And we came up with a process, and the process was called the campaign. And it was all around these questions. What do you want to do? What resonated with you? What can you work on that's reasonable? I remember people working on academic progression and nurses on boards and scope of practice, and it just, what goes around comes around. Did you all just do this for me today, just to make me feel like this has all come around? This
Coming
is
around.
so nice of you.
I think I do want to add that we know that asking you to fill in forms can be annoying, right? But it's for you to plan your work, but it's also for us to see where there's commonalities, because we know the real power of this campaign is when you share across just what happened today in this meeting, what's going on, what are some good ideas, what didn't work. I really appreciated that from Utah. Look, at that didn't work, we got to do something else here. So that's really what we're looking for. And I love when saying whatever's reasonable, like don't drive yourself crazy, but it can be incredibly useful to you and to the campaign as a whole.
And something else, if I may add on, is again, going reasonable. I was talking more about timing because that's what I was commenting on with some of the co-leads saying when they were scheduled this. I also highly recommend that you be reasonable in the amount of actions or goals that you take on. Going back to Sue's point, where 12 years ago, or whenever it was, right, almost 11 and a half years ago, numerous action coalitions wanted to take on all 8 sets of recommendations.
That's right.
And it was too much. And I remember saying, just take on 1 or 2, really, just BSN, nurses on boards, whatever. So again, I would do what's reasonable, but challenging. You know, challenge yourself with a new goal that addresses diversity, equity, and inclusion, that addresses structural racism. So, and I will say, I'm going to put a plug in for the schools that we work with on mentoring. So we work, there are schools in almost every state with which we work on mentoring. So they are the historically Black colleges and universities. They are the Hispanic serving schools of nursing. And there are American Indian, Alaska Native serving schools of nursing. It would be really great if the action coalitions, and some are already doing this, if the action coalitions partnered with those schools with whom we are working, because they need a lot of resources. They are, most of them are underserved, under-resourced, and what they are working on are also the goals that you could be working on. So by partnering with them, you could be achieving new goals and helping secure resources such as grant writing for them would be a win-win across the board. So just an idea.
We have a couple things in the chat. Arizona is meeting tomorrow, which is great news. We'll be using these tools. We have a question from Laura. I think it's Laura. Do our state AARP have this framework primed to help us with strategic planning?
I'm sorry, the state ARP offices? Is that what you're saying?
She said state AARP reps. That's what the question says.
Yeah, I don't see that. But if you want strategic planning assistance, that's technical assistance that the Campaign for Action, that CCNA provides. So shoot me an email. I'll put my email address in here. So shoot me an email with that request.
When I don't know if that was the intent. I'm wondering if Lori meant, and Lori, I guess, can come off mute. I don't know what the possibility is here, but I think she was asking if the state chapters know about this work and, you know, yeah.
Some are very involved, some are very involved, and you know, those action coalitions know who they are, and some are less involved.
Right.
And that doesn't mean they can't get engaged now.
Right. And Lori, you're in West Virginia. As you know, West Virginia was AARP very active and continues to be active on APRN scope of practice. I don't know how much you or your predecessor, Isla, engage, but I would be happy to connect you to the state director.
So
she's a big nurse champion,
That's
Gayleen.
good. That's what she's asking for.
So shoot me an email, Lori. I'll connect you to Gayleen.
Okay, so any other questions coming in? I don't see any other questions. See, I think it's pretty straightforward. Everybody's ready to roll. Looks
Good.
like some of them are already rolling.
And
Exciting.
somebody, Utah, Teresa in Utah said she's not aware of any of the Hispanic serving or American Indian schools of nursing in Utah. So Jasmine, if you're still on, yes, you are. I think one of the things that we can add to the hub is the list of the schools with which we engage. Because Teresa has also said, and if not in Utah, in surrounding states. So maybe this could even be a regional support effort. Okay, great. Thanks, Teresa. Yep, great. Thanks, Jasmine.
So
Okay, great.
in our last couple minutes, if you want to raise your hand, we can promote you to a panelist, and you can just say a few words if you'd like to do that. We can just open it up. So we'll see if any hands go up. Okay. All right. I think it's crystal clear, and everybody's just ready to go off and start
Good.
executing, implementing, and actioning. So Susan, any final comments?
Yeah, thanks, Soren. So I'm just incredibly grateful to Susan, her team at the Center to Champion Nursing in America, and of course, all of the action coalitions for the opportunity to improve health through nursing. It is so, as Ashley knows, she was there behind the scenes with me to really put something like this together, a report, and then to see everyone jump on it and want to take action on it. It's just the most heartening feeling ever. These 12 years of directing this campaign have been such an honor, highlight of my career, and I'm so grateful to have had all of you as colleagues. Yeah, I look forward to being with you again. I look forward to keeping in touch and following your work closely. So Susan, last words.
Yeah, we're almost at the hour. So of course, we all thank you, Sue. Tremendous contribution, and we'll, I'm sure, continue in your way to do that. And Ashley, we're so happy to have you as part of this work nationally and with our team. So we thank you. And Soren, your team, as always, has delivered big time. Win and your team, unbelievable. So thanks to everybody. Thank you, thank you, thank you. Bye-bye.
Bye,
See you
everyone.
soon.
Bye.
Bye.